Good morning, everyone, and thank you for coming to the Scrutiny Committee, Adults and Health today. I would like to welcome our guests who will introduce themselves at the appropriate time. Thank you so much for coming. Thank you for Mel, our officers, and our portfolio holder, and everyone else. And I'd also like to introduce, just to let you know, we have a new lady here, who's Emma Craigie. Is that right? And she's observing today, and she will be one of our other officers as well here at Scrutiny. Thank you. All right, so we hope we make her nice and welcome. Okay, we start with the first. I obviously you know who I am, Jill Slocum, Chair. I think you all know me by now. The agenda pack and papers is available on ModGov and directly from the Council's website from the link which is sent out to members. I'm requesting as normal that you turn off all microphones and videos, but please remember to turn on microphones and videos when you speak those online. This helps with background noise, call quality, and anything disrupting the meeting. So thank you to all those that are online as well. Thank you for attending today. When I invite somebody to speak, could you clearly state who you are for the benefit of anyone who's listening to the meeting so they can identify who is speaking? And I also remind all committee members that use the chat function. As we know, we don't need to be reminded about this. It is business only. And I also welcome members of the public media who's joining today. And all agendas are now electronically viewed. So I request that members refer to the page numbers as published on the agenda pack, please. So that we've got the appropriate information. So thank you very much. So if you can keep your videos off, please, online until you actually speak. That would be really helpful to us. Thank you. Apologies for absence.
Sorry, Chair, just bear with us. We just had a notification from someone online to say there is no sound.
Ah, you missed that? Better do a rerun?
Sorry, I apologise. I can hear you now. Thank you.
Thanks, Councillor Redmond.
Okay, good. Thank you. I'd like to invite Jamie to list the apologies, please.
Thank you, Chair. Good morning, committee. We have received apologies from Councillor Bailey and Councillor Robbins.
Thank you. Did we get? I think we did get apologies from Councillor Lawrence. Is that right as well? Yeah.
I can note those, Chair. Thank
yes,
you.
Please. I think that did come in, but I didn't think. Okay, the minutes of the previous meetings are on pages 9 to 22. Can I have your approval, please, that you agree to these minutes? Everybody in favour? Thank you. Thank you very much. Lovely. Item 3 is declarations of interest. I invite members to declare an interest, make them aware of the list on the committee members' personal interests as members of the district, city, town and parish councils is available for inspection on the website. So we do have that. Anybody else have any other interests? No? Lovely. Item 4 is public question time. And now I would just like to invite Alison Berkshire. You registered to speak on a topic of Frome Hospital. Alison, just to remind you, you have 3 minutes and we will let you know at the end when you're nearing the 3 minutes, please. Thank you. Alison, would you like to speak now?
Fine, thank you. My name is Alison Berkshire and I worked in the NHS. And when working for Bath and West Community Trust, I wrote the business plan. Sorry, can you hear me?
Yes, we can. Yes, we can. Everybody online, can you hear?
Sorry?
Everybody online, can you all hear? I don't know if they can. Just one moment, Alison. I'm just going to make sure everybody can hear.
Okay.
Yeah, they're good. Okay, carry on, Alison.
Fine, thank you. I wrote the business case for Frome Community Hospital, including the rationale for the number of beds, which was based on best practice at that time. I want to raise the issue of the proposed closure of some of the beds at Frome Hospital. My understanding is that the proposal is to reduce the number of beds from 24 to 16. The business case I wrote was predicated on reducing the average length of stay to best practice at that time. Information from Somerset Intelligence says the Somerset population in total was projected to rise by around 73,400 or 12% overall from 2016 to 2041. And the projected growth amongst that of the 65 plus age group was around 35%. And the number of people aged 75 or more projected to almost double over that period to almost 117,500. Given the number of new houses in Frome and surroundings and the number in the pipeline, this could well be an underestimate. Whilst I acknowledge that some medical practice may have changed since the hospital was built, which may have reduced the demand for some beds, the increase in the elderly population will have countered that by increasing the demand. According to the NHS Somerset Performance Report that you have in your meeting papers for today, adult bed occupancy has remained high, particularly over the autumn and winter period at around 96%. The number of patients in hospital beds with no criteria to reside, i.e. are fit for discharge, is higher than planned levels. At April 25, it was 23.1%. So it would appear that it's proving fairly challenging to discharge patients, presumably because there is insufficient alternative provision to meet their needs. I'm not clear from the information provided in the report whether this covers the whole of the Somerset population or is just relating to the Somerset NHS Foundation Trust facilities, i.e. Taunton and Yeovil hospitals and the community hospitals. Does it include information which relates to Somerset patients that are admitted to the RUH and who are often discharged into Frome Community Hospital? I think this is an issue both for the Integrated Care Board and for you, Somerset Council, as you do have responsibility for the entire population of Somerset. My reading of this report is that it doesn't cover the RUH flow. Has Frome Community Hospital been identified to have bed closures because it does take patients from the RUH, and therefore if reducing the number of beds causes the RUH some difficulties, it won't impact on the performance of Taunton and Yeovil hospitals? Is it possible and realistic to do more care in the community and reduce the number of beds? If it is true, then this should apply across the whole of Somerset, and they should be looking at reducing beds in all of the community hospitals. And this is not my understanding of what is proposed. If it's a money-saving exercise, then the money saved will be absolutely marginal. You're still going to have to maintain a hospital, and therefore, you've got to maintain safe staffing levels. So any savings will be very minimal. If we're going to say that there's going to be more care in the community, then what additional resources, including staff, are going to be put into that community support, presumably eating up any savings? And if no resources are going to be put in, then how is more care going to be provided in the community? Will social care be required with a knock-on impact on Somerset social services? Will this be means tested and individuals have to pay for private care if they can obtain it? As we all know, care is difficult these days. How are elderly people living on their own expected to manage? I understand that it's proposed that there will be a pilot over the summer, but the greatest pressure on the NHS is over the winter. So even if this pilot looks as if it is working over the summer, you can't assume that it will work over the winter. So my questions to you are you aware of these bed closures? Have you been consulted? And if yes, how do you justify the loss of these beds? Will you be involved in the evaluation of the pilot? Is the population of East Mendip being disadvantaged by closure of these beds because of the patient flow to the RUH, not impacting on Somerset hospitals? Is Somerset Council expecting to have increased social care demand as a result? And if so, can you deliver this?
Thank you, Alison. Thank you for your question. I've been very good today because I've given you well over 5.25 minutes because I think
Sorry.
That's okay. It was very interesting and we appreciate your time and coming forward today. I would like to ask, invite David McClay to respond to you, please, if I could.
Thank you, Chair. Thanks, Alison, for a very well-informed and comprehensive question on an important topic. I'm going to set the scene I'm David McLean, Chief Officer for Strategy, Digital and Integration at the ICB. I'm going to set the scene around the kind of direction of travel. I'm also joined by Andy Heron, who's Deputy Chief Executive at the Somerset Foundation Trust, who are leading the piece of work. So he will speak a little bit about the detail of the trial itself. And so you're absolutely right. I haven't had time. I got the question last night. I haven't had time to go in and look at all the information you've contained in there. I'm very happy to work with you outside of this house and to pick up some of the questions you've got within the question itself, if that makes sense, and to double check on some of the data that you've quoted back. You're absolutely right in terms of increasing demand, growing elderly population, and you're absolutely right. If the model of care stays as it is today, we will need more and more beds moving forward. But that's not what we want to do. That's not. We know from experience and from evidence that that the provision of beds and bedded care isn't what people need. And we know that from patient experience that actually the best bed that somebody can be in is their own bed. So we put a challenge into the system this year around how can we re-provide care in a way, and how providers in the area can re-provide care in a way that ensures more people get care in their own home with a degree of support that they need, or they get a placement in a care home or a place of residence near their own home that isn't in a community hospital or isn't in an acute bed. So how do we improve the flow of people right into their own bed? And that's the overall objective. And we need to do that for a variety of reasons, but particularly because of the growing demand. And we don't have the people, we don't have the resource to rely on bedded care moving forward. So there is a conversation we do need about the beds we've got within the system, both within kind of the acute environment, particularly within community hospital space. So how do we innovate in that space? How do we use the modern technology that we've got? And how do we open up alternatives to that? And the trust have put forward a test and learn, which Alison has referred to, and that's in around the Frome area, Bridgewater and West Mendip. And that tries to sort of apply a different model and a different way of working that seeks to kind of mitigate that growing demand that we have in reliance we have on bedded care. So I'll ask Andy to sort of talk a little bit about that, because he and his team have been leading that, and I'm happy to pick up at the end about the assurances we're putting in place from an ITB level and how it will play into this group.
Thank you, David, and good morning, Chair and committee members, and Alison online. Alison, I'm fascinated to hear that you were involved in the origins of the hospital, and it's an excellent facility and continues to be and will be a hugely important part of our services going forward. What I would say, though, is that what we are doing at the moment isn't a sort of one-off event. Actually, it's part of a joint approach to transformation that we in the NHS have taken very closely with our colleagues in social care, and a journey that we've travelled together in recent years. So since the business case was written for Frome Hospital, in fact, over the last, I would say, 5 or 6 years, the NHS and the council between them have invested about £16 million in intermediate care services, new 7-day community services that are aimed to sustain people in their own homes. That includes an additional £1.7 million this year that has gone into additional home care. We've known for a long time, it's not just us, but nationally, there is a tendency to put too many frail older people into bed-based care, where, of course, people decondition and it's harder to get home. In fact, of all the people who go to our community hospitals, only about 40% of those people end up going home. And about 50% end up going to some sort of care home. And sadly, quite a number of people die because being moved as an older person is quite a traumatic event. So what we're doing at the moment, and I think to answer one of Alison's questions, the 13 community hospitals that we've got, the beds are not equally distributed across the county. We have a much higher concentration in the north of the county, and particularly relative to population in the Mendip area, where we've got West Mendip Hospital and Frome hospitals. As Alison mentioned, the sort of catchment, we provide the community and obviously social care services to that population. Acute services are provided by our neighbours at the Royal United Hospital. We're hoping that colleagues at the RUH will be looking to do what we're looking to do in the hospital, the other hospitals. We're reducing beds at the moment, which is not just to leave vacant space, but to fill that space with other opportunities such as ambulatory care, which is massively important to local communities, services such as chemotherapy, urology, spaces for maternity hubs. There's a whole list of what we offer now from community hospitals. In many ways, there's an association, very understandably, so much affection for community hospitals in the county that they are bed-based facilities. Actually, that is just the tip of what they do. And just, I suppose, lastly, what I would say is that with the publication of the 10-year plan last week, which is hugely exciting, I think, for us in Somerset, there is a description of moving more acute services from our acute hospitals into local neighbourhoods, into what will be called neighbourhood health centres. We think that community hospitals are potentially massively important assets in delivering that. We're super keen to get as many services close to our population as possible. So there's a sort of broader context, really, is what I'm trying to get across, is a change in services and as we deliver services. And I know it's not the same, but it in many ways, you know, if you go back to the 1980s, Somerset had probably 500 mental health beds for its population, if not more. It's what I estimate across what were the two Victorian hospitals at Wells and at Tone Vale. We now have 122 mental health beds. We very, very rarely send patients out of area. We're one of the highest performing services, and that's because we've got an extensive range of community services. And 3 years ago, we were the Health Service Journal Trust of the Year. Services are changing away from bed-based care into better community services, and that's very much what this is part of.
Well, I'm mindful of time, but just to pick up, so we had a session, Alison, with the committee last month on the alternatives, our intermediate care work that Andy's just described, and the investments gone in there. So the committee is aware of that. We've got a paper coming, it's due this month, will now come next month, to describe the work that Andy's just set out. And as an ICB, we're working with the trust and with other providers then around the criteria that need to be met in order for the pilot to commence. Pilot's being monitored as we go through it, and then what the process looks like if that pilot is successful. So just to give you some reassurance on that. Thank you.
Thank you both very much. Very comprehensive, and it's very, very good to hear. Alison, we don't give an opportunity to come back, but I'm sure that either David or Andy can come back to you if you need them to. Would that be all right?
Yes. Would it be possible to actually, I mean, presumably you'll take notes of the meeting, but actually have written answers to the questions that I asked?
Yeah, very happy to do that. So you've got the 5 questions at the end. You've also got a number of questions in the body of the text, which I'm happy to pick up as well. So we'll get a response to each of those outside of this.
Thank you. Thank you,
Thank you.
Alison. Thank you for giving your time today. Very, very good question indeed. Thank you very much. Thank you.
Thank you.
Right, the next item on the agenda is the number 5, which is the work programme. And as you'll notice, there's a note there that the homeless and rough sleeper strategy has been moved to October, and a new item on trauma-informed service support for adults facing homelessness or multiple exclusions will be coming to the August meeting. Now, when I read this, I was somewhat confused, and I gather that Mel will be able to explain why those two things are separated, because they are slightly different.
I think it is about us thinking through how do we do some of this together, because although they're different, there is connections between them, hence why we wanted to pull that into one space at that meeting, and we will do that for you so that you can see the interconnections, but also how we take that forward.
Thank you. Thank you very much. Thank you. So members, you will see that on the August work programme, we have Musgrove Park Hospital, we have the homeless and rough sleeper strategy action plan, and then we're talking about community hospitals. And we were also wanting to talk at some point, I think in the next meeting, about the transportation from Yeovil to Musgrove to see how that's working, to see if there's any issues. Does anybody else have any they'd like to bring up, please? Councillor Hobbs.
Thank you. As discussed before the meeting, I would like to discuss and raise awareness and maybe do a piece of work around response times with the 999 service for accessing defibrillators. I discussed this with councillors Sally the other day and you, Chair, just before the meeting. A friend of mine had the need to use one of the public access defibrillators in my division a few days ago, and they actually spent, having dialed 999, 4 minutes online to the operator answering questions, which she was unable to answer. She'd been sent to get the defibrillator, while her husband successfully performed CPR and the ambulance got there. And I would like us to have somebody maybe from who deals with 999 calls, why it takes 4 minutes before somebody can be given a code to get a defibrillator. Because there's those of us who've done any form of CPR training will know that's too long and a person could be stone cold dead before you get a defibrillator to them. So I'd like us to do some work around maybe improving response times and maybe somebody to answer why it takes so long to get a code in some of the rural areas where these defibrillators are situated.
Is anybody, I've got defib in my ward and I've not experienced any issues at all. The code was there and it was all done. But it does seem there's an anomaly here, and I think it would be worthwhile perhaps getting somebody in who knows about defibs to actually perhaps explain this issue. So I think it's a fair point. Is everybody happy about that, to put that on the work programme? Thank you very much, Councillor Hobbs. Thank you.
Thank you, Chair.
Thank you. On the October, sorry. Oh, apologise, Councillor. Councillor Woods, sorry.
I haven't got the agenda and I apologise for that because I cannot see it on my computer. But can I bring up the fact about Minehead GP surgeries before the end of this meeting, please?
It's not on the agenda, Councillor Woods, but we can do it now if you wish to bring it up now. Bring it up now.
Thank you very much. It has been to my attention, and several people have brought this up, that Minehead is not well served by its GP services. I've been told that it takes 6 weeks to get an appointment, but they haven't got GPs in post. So it needs something done because they are totally without GPs most of the time in Minehead. Thank you.
Thank you, Councillor Woods. That's one of the things we were going to bring up on our forward plan about general GPs, surgeries and appointments. So maybe we could put that on the forward plan.
But it's not the same over the whole of West Somerset. No. I have a Willerton doctor. They have no trouble getting doctors in. I cannot see why Minehead is totally lacking GP cover.
Mel.
Rather than trying to manage this in this meeting today, perhaps what we can do is we'll have a separate conversation with David and yourself outside this meeting, because I know there are information afoot in that space.
Yeah, very happy to catch up outside of this, Councillor Woods, and brief you on
If I
that.
make it there.
Thank you very much, David. Again, it's good to have somebody here who's got all the answers, as always. So, but it is something we do need to bring forward, I think, to the forward plan about GP surgeries. I wonder whether everybody would like that, because I've had a few members ask me they'd like GP surgeries in general to find out how it's working, because you know, there are some surgeries that seem to be running very well, some that are having major problems. So on the November, we'll put GP surgeries. Is everybody happy with that?
Yeah.
Does anybody have anything else that they would like to bring forward, please? There's also armed forces covenants on that day as well, we're bringing forward. Does anybody else would like something else, please? If you do think of anything that you'd like forward for the forward plan, it's always good, and it gives our officers enough time to get the relevant people and relevant information. Councillor Bruce.
Thank you, Chair. I was just wondering at what point the social care training, the Bridgewater Academy, will come into the agenda, which meeting that might be.
Max, do you have that information? No, we don't. No.
Perhaps I think we bring that in probably December time is probably the right, when we've got a bit more information for you in that space. I think that's probably the right time to do that. And in terms of your GP, you might want to phrase that as primary care rather than just GP, but we work with you on the title of that.
Thank you, Mel. Thank you. It's always good to get the right title. Otherwise we'll end up with some of the wrong people. So thank you very much. Lovely. Thank you. Okay, well, with nothing else then, we'll move on now to item 6, which is maternity services improvement. And I think I'm going to invite Leanne Ashman and Sally Bryant to speak. Then I will invite members to speak afterwards and ask questions in a normal way, where I know that you'll get hopefully get the answers that you want. So can I hand over to Leanne, please? Or is it Andy? I apologise, Andy.
No, thank you, Chair. I just wanted to really just to open this piece and introduce colleagues before handing you over to colleagues who are so much closer and have so much more detail of this. So this item, thank you for inviting us back, as I think we've been a couple of times before on this topic. And the origins go back to November 23, quite a long time now. And a CQC inspection, which, as the paper says, we were found wanting in our maternity services at Musgrove Park Hospital and also Yeovil District Hospital. And after picking ourselves up after that, we have set about quite an extensive programme of change and improvement, which has continued and is continuing. And in a moment, I'm going to hand you over to my colleagues, Sally Bryant, who's our Director of Midwifery, and also we're delighted to have with us Donna Butland, who from the Maternity Voices Partnership as well, who's closely working with us in that territory to describe some of those improvements. And then, of course, it wasn't actually what we were here to ostensibly talk about, but we've got the very important new development of the recent temporary closure of services at YDH, which is obviously of great concern to people in Somerset. We're very sorry that we're in that position. My colleague Leanne Ashmead, who's our Service Group Director for Children and Young People Services in Somerset, is going to describe a little bit more about that and some of the work that we're doing to try and recover the position from that point. Then, of course, we're really happy to take questions. So if that's okay, Chair, I will now hand over to Sally and Donna.
Thank you very much. Thank you.
Thank you, Andy. Thank you, Chair. Good morning, everybody. And as Andy said, we're here. The agenda item today is talk about maternity improvement. So I won't labour the points on the detail of all the key lines of inquiry that are in the paper, but I'd like to give a little bit of an update on those, if that's okay. So as you know, we've undertaken a huge improvement programme since CQC inspected us in November, and we've made great progress with our CQC action plan. A little update fresh off the press to what's printed in the paper. We've now closed 94% of all of the actions in our CQC plan. There's one remaining should do action that is still open, and that is to do with recording some data in multiple systems, just to make sure that we've got seamless data sharing across several different digital platforms that we use. But the improvement doesn't stop with the closure of our action plan. We're still very much on an improvement journey and working with Donna, the colleagues from MMVP and from the National Maternity Safety Support Programme to help drive those improvements into what we see as a new business as usual. So we're bringing together all of our improvement work, all of our CQC key lines of inquiries, and anything else that we know or we feel needs improvement under one overarching improvement plan for maternity and neonatal services for Somerset. It's a really big plan. It's really complex. As you'll all be aware, there's a huge amount of national scrutiny and recommendations for maternity services. So we're picking all of that up within that plan and working really hard with all of our stakeholders to capture everything that we need to improve, but also, rather than just improve things, make things really, really, really great. So we're really striving for excellence across all of the domains within the plan, and we're really promoting quality improvement and use of quality improvement embedded within the maternity teams to really strive for excellence in all areas. There's lots of work ongoing. It certainly won't close when our CQC action plan closes. Just give it a little bit of data on some of the key lines of inquiry. So our triage service, which has undergone a complete reformation, really, both logistically within the footprint, but also within how we conduct maternity emergency triage with the implementation of a BSOTS, which is a specific tool to make sure that any woman who is calling or attending with any concerns throughout the maternity journey is seen within the appropriate timeframe by an appropriate person and is risk assessed and care delivered according to the need. We're really pleased to say that we are seeing over 80% of women that attend triage are having that initial assessment within 15 minutes with a midwife. So that's really, really good progress. We still are experiencing some delays with ongoing medical reviews for some of those women as part of ongoing capacity challenges that I think we're not unique in having in maternity, but that's certainly an area of continued focus for us at the moment. We've made huge strides in our governance audit, monitoring of data, and our MDT kind of learning and audit reviews and audit sharing of learning from audits. And we now have monthly MDT away day that any member of our maternity neonatal team and Donna often comes along as well. We share audits and learning from those audits and look at improving practice from that. So that's a huge success. Our training compliance has really come on leaps and bounds. We have managed to achieve the 90% target for all of our mandatory maternity specific training across all staff groups. And we continue to strive that. Overall, we've now got over 80% compliance across all mandatory training, not just the maternity specific ones across staff groups, which is a real leap in progress. We've particularly focused on safeguarding training in response to our CQC inspection, and we've now got over 90% of all midwives fully compliant with both adult and child safeguarding. Again, slightly more challenge within our medical team's capacity to undertake the training, so the compliance rates are slightly lower at around a total of around 70% across the adults and children. So there's still some work to do, but we continue to really focus on that. Really investing in our people. As you'll be aware, all of this improvement work is really hard going on people, as well as we've got people coming through the doors literally every day and night. That doesn't stop, so there's a lot of work to do. So we're really focusing on working with our teams and supporting them. And our appraisal rates are now sitting between 68 and 100% across all of our staff groups. So we're really working hard to engage in our staff and support them. And then the other one, of course, estates. You'll be really aware that we're really challenged with our maternity building, particularly on the Musgrove side. So we've had a huge investment in improvements across our whole footprint with installation of new fire doors. We've got lots of work around security. Now I've got 24-hour security guard presence on the site, so they're welcomed into the team, which is really, really good, and improve things like swipe access across all areas of the unit. The estate is a challenge. It continues to be a challenge, and there, no matter what the weather, there's something that surprises us. So it's often something that we are pulled into addressing, and we all know that we're very much hoping for a new hospital at some point. But we are doing the best we can, and we will continue to invest in our estate as we continue to use that. We are starting to think about a CQC reinspection, and we know that we're likely to have an inspection probably within this next calendar year. So we're starting to move away from being reactive and being a bit more, getting ourselves in a positive space ready for that. We've undertaken a few deep dive audits into our data so far, and we're just planning a couple of mock inspections with Donna and the team and others from maternity services outside of Somerset to come and lend a fresh eye on the service so that we can best prepare ourselves to be even better when CQC come back next time.
Thank you very much. I want to ask you a question in a minute, but I'll ask it.
Good morning, everybody. It's nice to see you again. I'm Donna. I'm the Service User Voice Lead, leading the MMVP, which is the Maternity and Neonatal Voices Partnership. So we're independent, but I've worked alongside this team, well, actually not this team, because I was here before this team, for about 6.5 years. And if it's okay for me just to give a little bit of history, because I think it will give some reassurance about how involved and embedded the service users in our local community are. 6 years ago when I started, and not long after that we had COVID, which was the time where we really understood the fragility of not only people having babies, but everybody's lives. And I think that really hit the NHS quite hard. And it was really important for us to be involved and respond to the needs of the community at that point. So it really helped us to show the value of being alongside things when there was a crisis. And alongside the team, we supported the merger of the two acute sites, the two maternity teams coming together, involved in a lot of the planning with that and making sure that they were responding to the community immediately in the changes that they were planning for those mergers. I've also seen the change of going from paper to digital, which was a challenging time, I think, for a lot of people, for service users to move from that to their digital systems and for staff to get their heads around to that. And then shortly after that, we had a lot of recommendations that we've worked through with our community to make sure that not only are we looking at the national safety recommendations and new pathways and processes, but alongside that, making sure the voices of people are heard. And that it meets the needs, and we're involved from the beginning of those things. So things like the Ockenden Saving Babies' Lives. And then I think from my perspective and working with the community, it's quite probably understandable that when you're having a lot of change, that can be really difficult, I think, for people on the ground and for service users to understand the context of those changes. But through that whole process, we've been included and made sure that anything that happens, we're engaging with people who are having babies right now, so their voices are at the heart of that. And then the CQC report, what you won't see in the CQC report is, or one of the things that I think is really important to mention in the CQC report is how they talked about the engagement and involvement of the community. And I think that really sometimes can be missed when you're looking at a lot of safety actions, is understanding that alongside that you're making sure that services are of good quality as well as safe. And that's what we do with the MMVP. In that time, I've seen a real shift in how people within the organisation listen to the voices of people who are having babies, who really want to understand what it feels like for those people, but not just everybody, not just the majority, but everybody, and particularly looking at those people who are underserved and unheard and making sure that services are becoming equitable and psychologically safe. We've worked alongside the organisation to change things in guidelines to make sure language is inclusive, that it also talks about things in a way that if the language is in our guidelines, in our processes, changing things like fetus to baby, to management of people, to the care of people. And I think that's really starting to, or really has showed how you can change culture in making sure that care is personalised and of good quality, and that people feel that they're having a good experience. And I think that there's a real can-do attitude and resilience within the teams now, but also that the people who are working on the ground have really struggled to have a lot of changes and a lot of scrutiny, and that the service users that are at the heart of that are being well supported by those people. And that along the 6 years, the feedback and the care that's received, I think, has stayed at a really high level. Obviously, maternity, having a baby, the moment you become pregnant, you're scared, there's fear, that's not going to go away. Every day you're worried about yourself and your baby. So anything that is added to that can be really challenging. And I think the main thing that's important while we're doing this, and that I feel that is happening, is that we're really clear with our communication, that we make sure people have the information that they need, and that they're supported by midwives and doctors who are dedicated to be able to make sure that they can have the best experience that they can, and that their care is personalised on that process. So I'm a little bit nervous. I think as service users, and when you're working with the community, it's so much more than all the things that you see in reports and in processes and ticking boxes and making sure that we're going through things. There are real people, staff and service users at the heart of this, and that's what I try to bring to everybody who is doing a good job at the things they need to do to allow them to be able to do those jobs. Is to make sure that that lay person, that those fresh eyes, the voices of people are included in that. So I'm very happy to answer any questions about specifics with regards to feedback.
Thank you very much for the report. I mean, the one thing I would ban is acronyms. I spend half my day going backwards and forwards, wondering what the CPD and the doobie-doo and all the rest of it. So I have to say, I think that excludes us as a society because we don't know what they mean. The one thing this has been a very difficult time, and I do appreciate that for everyone. I think it seems to be so easy to criticise, but very difficult to praise. And we commend you for the work that's been done. We want to make sure we don't want to have our maternity in Somerset down like this in any way at all. So we want it to be a lot better. So we're very pleased. One of the questions I want to ask before I set the scene is you mentioned about medical. There is still a problem about the medical issues getting to see doctors and things with the maternity. Could you just expand on that a little bit, please?
Yes, of course, Chair. So my apologies if that's confusing. Our medical team, we've got some vacancies on the Musgrove site and it's really, really busy. Our midwifery team is easier to support to some time out of the clinical day to undertake some training, much easier than it is for our medical team, because when there's a little bit of a gap in even one person, one vacancy, our doctor's time is predominantly clinical. They don't have as much sort of administrative time or time for training as the midwives do. So it is easier for us to support the midwives to access training. Sometimes it's more challenging for the doctors to take time away from what is in front clinically to go away and do 3 hours training. So it is more challenging, and a lot of this is a bit of a balance game dependent on what work we've got on the day. So sometimes we might have 3 doctors scheduled to undertake a training day, but it's really, really busy and somebody's gone off sick. So they come off the training day and go and deliver the care on the shop floor. So it's just there's less flexibility. There are fewer doctors than there are midwives. So it is harder for the flexibility to cover both. Does that make sense?
So it's a resource issue as much as anything, isn't it?
Yeah, resource and time for our colleagues.
I think that would be nice to have that actually said in the report, if I may, because of that. I was a bit confused and I just thought I needed to check that. Okay, can I go to, sorry, I just want to go to Mel first, if I may. Mel, do you wish to say anything at all? Okay, Councillor Sally.
Thank you very much for this excellent report. Sorry, can I just ask your name again? Yeah.
It's Donna.
Donna, it's really good to hear. It's so eloquent, articulate what you said, and very powerful. When you were last here, you did speak, and I did say, you? Yeah. Just at the end. Just at the end.
I listened and then came.
Yeah.
Yeah.
I think I made the comment, we'd like to hear more from you, if I'm allowed.
Thank you.
Everyone's more alert than me, obviously, no. And I just, but that was really good. I've got a couple of questions. Let me know if the one question isn't in scope. But the first question is, I observed a get together protest campaign led event outside the maternity hospital, and when it was visceral when the staff came out, they were all in tears, and which reflected gave me an impression of how the staff were feeling. So my question around that is, how are they feeling? And the second question is, how is recruitment going? Because that seemed to be a heart of the issue, having enough senior, highly skilled professionals to allow you to open the maternity ward again. So is that okay? Those questions okay? Yeah. Thank you.
Thank you. Thank you. I'll respond to the how are the staff questions. That's all right. And I'll hand over to Leanne to talk about the recruitment. So, yeah, really difficult time for everybody. Difficult for all of us, difficult for all of our staff, and difficult for the community, of course. The staff had the rug pulled out from under them really quickly. And like I said when I was here previously, the first thing they did was, how can I help my women? They got on the phone, they went out to visit people, they made sure that people felt safe and wrapped around at all times. And there is always, in a crisis, people really show their true colours, and the staff have been incredible. I can't tell you how proud I am of all of our staff who've just been amazing and put their service users and each other before themselves on all occasions. It's been really quite humbling. That said, it has been really difficult. So the Yeovil staff have been redeployed to various different services and various different areas. They've done it amazingly with dignity, compassion and pride. The team in Musgrave have been incredible, welcoming the Yeovil midwives and support workers into the team. They've made welcome gifts and they made some little videos to explain what it looked like there and really welcomed them into the team. I think with everything Donna said, you know, in maternity, certainly for midwives and midwifery support workers, we've had a lot to go through in the last 6-7 years, and it's really difficult. So people are tired, and I think recent events have definitely taken a toll. But we are really focusing on wrapping around support for those staff as well, working with our unions, our HR colleagues. We've got somebody whose title is a retention midwife, whose job is to look after staff wellbeing, to make sure that all of us are doing everything we can and running a series of programmes to support staff. I think the important thing is we keep listening to staff, offering opportunities for staff to talk to us and responding the best way we can to any challenges they have. So people are tired, but they're working really hard and they're still putting the service users at the heart of it.
Thank you very much. Can I go to Councillor Trimnell, please? Oh, I beg your pardon. I'm sorry. I didn't know there was two. Sorry.
Morning, everyone. I'm Leanne Ashmead. I am the Service Group Director for Children, Young People and Family Services at Somerset Foundation Trust. So the recruitment question really relates more to paediatrics, and I was going to pick that up under my paediatrics update. So do you want me to just pause there? You finish off the maternity item and I come back to address that in paediatrics? Is that okay?
Thank you very much. Okay. I'll now go to Councillor Trimnell.
Thank you, Chair. So thank you so much for coming back and giving us that presentation. It's really important that we hear what's happening. It sounds like there's an awful lot of progress, and I'm really pleased to hear that. I had a couple of questions. It says on page 30 on item 6 that other services, not other services, but you've had to use more area of Musgrave Park Hospital to accommodate the extra capacity that you've needed to make. And I wondered whether any other services were affected by that, whether you've had to reduce anything or whether you have the space already to do that. I wanted to know about the continuity of care, because if you're under the care at Yeovil District Hospital, antenatal services are still continuing there. How does that work? Because there was a sort of a drive to try and get that sort of consistent care throughout from the same midwife, and even if when you were birthing, if you could have the same midwife, which I can't see is always possible. But how does that work when you're working under a team in one hospital and then giving birth in another hospital? And are the obstetricians or the obstetric consultants still based at Yeovil Hospital? Have they been redeployed to where the need is more, or is the need more? I don't know. And then I also wanted to know just about, in terms of home births, have you seen a rise in home birthing or requests for home births from women in the Yeovil District Hospital area where they feel as though actually it would be easier to do it at home than travel out to Musgrave? And if so, is that sort of successful?
Thank you. In relation to your first question, in order to create additional space at Musgrave Park Hospital with the temporary closure, yes, we have been impacted on the Musgrave Park site. We have effectively handed over what was previously our private patient unit, private patients, mostly for surgery. Like most trusts, we look to supplement our income, our finances with a private patient offer. So, yeah, people can either go to the Nuffield or Shepton Mallet, or they could choose to have a private patient appointment with us. Obviously, priority was given to maternity services and safety and all this. That does cause us a problem. It causes a problem in that that will leave a hole in our finances in what is already a very difficult year. It's also a reputational challenge for us, not necessarily in the wider sort of public, but in terms of it's a competitive business recruiting surgeons. And so being able to have a private patient offer and the surgeons be able to do extra work, delivering private patient care is a loss. So yes, it is a problem for us, but of course, we will always prioritise safety, and in this case, and as Sally has already pointed out, the estate that the maternity services have is very, very poor at Musgrave, so that additional resource has been handed across, but yes, it is problematic.
Thank you.
Thank you. Can I go to Councillor Govier? Oh, I beg your pardon.
Just, I think a couple more answers.
Oh, I apologise. I'm sorry. I'm not meaning to race along. I apologise.
Thank you, Chair. I'll come in back with questions around the care, if
Thank you.
that's okay. So in Yeovil at the moment, yes, the consultants are still running their antenatal clinics. So anybody that was previously under consultant, their care is still seeing their scans and their follow-up appointments. The community and midwifery service is exactly the same, completely remains unchanged. In fact, we've got a few more midwives working within that team so that we can have enough and repeated conversations so that people are brought up to date with any new information and opportunity to discuss their choices as well. So the continuity of care, that the national drive was around midwifery care, that hasn't changed. So the women in the Yeovil area will meet their community midwife, and you're right, it's not always 100% of the time the same midwife, but where possible it'll be the same midwife or a small team of midwives that they get to know throughout their whole journey. The ambition is for that midwife or somebody that person knows to be the person providing the care in labour. That's not always possible, and it depends on suitability, etc. What we are doing since the closure is working really closely with our Dorchester colleagues. So if the Yeovil community midwives are still looking after the lady who's then going to have a baby in Dorchester, there's open communication between the midwifery teams. And in fact, we had a home birth not long ago where we had Dorchester and Yeovil midwives working together to look after a family, which is really lovely. And we're working really closely with Dorchester to make sure that people that are having their baby there understand their choices and what the facilities and things look like in Dorchester. This in the same way that we are at Musgrave. We're meeting weekly with Dorchester, and then there are several clinical team meetings around specific pathways as well. So we're really trying to make sure that care isn't confusing and disruptive for people. We're having some really good feedback around that as well, and we're listening to people's experience and making tweaks and changes along the way as we do that. And then the other question about home birth, we haven't had an increase in asking for home birth. I can give you a few statistics if that's helpful since the closure and where people have had their babies. So at Musgrave, we've had 59 of the original Yeovil booked babies born at Musgrave. Dorchester have had 58 today. This is hot off the press this morning figures, and there have been 8 home births in that time, which is about the average that we would expect to see.
Thank you.
Is there anyone else before I move on? Because I don't want to. I'm going to Councillor Govier first, if I may, but I'll come to Councillor Crosdon after.
Yeah, Councillor Andrew Govier from representing Wellington Division. Well, I'm delighted to inform the committee that I became a granddad in May when my daughter gave birth to baby Leo George at Musgrave Hospital. So I've got up to date.
You're too young.
Well, thank you. That's very kind of you. Don't feel it sometimes, but then. But no, but the point I wanted to make was along the lines of how well the staff operate in what is a very difficult environment. You know, we had calls to visit my daughter. She had the birth was quite well, but she had a significant bleed after the birth and had to go for a surgery. But when we went in to visit, it was quite clear that the staff were doing the best job in very difficult circumstances as far as the accommodation was concerned. And I think we as a council need to be putting pressure on to get that facility updated as soon as possible, because it's pleasing to hear the improvements being made to the staff, but the environment they're working in makes their job, and to my mind, as just a lay observer, it was incredibly difficult to carry out safe baby care and support for mothers and families in that environment. So I think we need to sort of keep the pressure on to get something updated there, and obviously with the change from Yeovil, which we understand why that change was made, that's put extra strain on the people based in Taunton and those buildings. So thank you from me for the support my daughter received, but a plea for us to continue to support the case for better facilities for maternity, because I think that is a key, and once that's delivered, all the staff side of it will flourish as well. Thank you, Chair.
Thank you very much for your shared experience, because I think that's what we need, somebody to be in there. I had my children many years ago, and things were pretty bad in Musgrove then, and they kept saying to me it needed updating. So you're absolutely right. There's something we need to work on. Yeah, we need to work on that, and maybe this is something this committee can go forward and do, because We need to look after you staff, we need to look after everyone, but we need to look after the building they're in to make that safe as well. It's all very well doing all this safeguarding, but you know what? If the building's not safe, that's no good. So councillor Pearlstone.
Thank you. I'm not sure it's that the building's unsafe, it's just very well worn and weathered.
Very well.
I maybe you could go with it brings about hardy mums and babies, you know, because you just have to get on with it. But working there, I'm sure, is incredibly tough. I am curious as to, it's a bit of a follow-on from Councillor Trimmell's question about home births. How is it going encouraging mums to consider, you know, going a bit old school and having their babies at home surrounded by many more loved ones that they could be? Because I think that would be quite nice if possible, and safe, obviously.
I'll come in if that's okay, councillor, and then I'd be quite interested for Donna to support with her thoughts around this as well. I would say, hand on heart, I'm a community midwife by background. I have a huge amount of experience of supporting people to have their babies in their own homes, or their caravans, or their sheds, or wherever they choose to have their baby. So I'm maybe slightly biased. You know, where you birth your baby is your choice. And we as a service aim to support any person who chooses to have their baby wherever that is, as long as they have the right information and they understand if there is any risk around their choice, to make that decision. And then as midwives, we will support that person through whatever that choice looks like, and provide the best care we can. Home birth the demand for home birth has significantly decreased, certainly since I was a student midwife. You know, there was the area I worked out around Exmoor, West Somerset. We had about 25% of our caseload had home births at any one time. Now we're around 2%. That's a combination, I think, of the appetite to have your baby at home, but also people who are having babies now are probably have more medical, social, various different risks that perhaps weren't as prevalent 10, 15, 20 years ago. So the risk profile has changed. So people make choices around that. We also do a lot more monitoring now in pregnancy. And if you scan somebody enough times, then that starts to make people think there might be a reason for them not to stay at home. People don't feel quite as safe perhaps as they used to. So there's lots of sociological and biological reasons, but it's certainly something that I'm very keen to advocate as a choice for people always. And I think we're at a bit of a, if I may get on my soapbox, we're at a little bit of a crucial point in time for midwifery, that if we don't protect the art and craft of midwifery, it won't be there because we won't be able to practice those skills.
Excellent answer, thank you.
So Andy said that I could say anything, so I'm going to.
You're so much like me.
So I think it is really difficult when we start worrying about what's happening, scrutiny, the safety, for people to really stay on track with looking at choices, informed decision making, and you know, allowing those choices. And one of the things that I think is really useful about having a helicopter view, and I talked about equity and making sure people have personalised care, is that we don't get bogged down with specifics around whether we're going to have a home birth, a cesarean, what those choices are, but that we really focus on making sure that people are met where they are right now, their questions are answered, they get the information they need to have those decisions and make those decisions, informed decisions, so that they can feel happy that they're being listened to and they can have the best experience possible, but also that staff feel reassured and they feel safe to be able to provide care to people who are making the choices. So I think that's one of the things that I continue to try and talk about, is that, you know, if we're looking after people with what they need, wrapping around them, as Sally always talks about, which I think is so lovely, you know, wrapping around them with everything they need, then we don't have to worry about whether that choice is a home birth or cesarean. And the thing that I want to say is that, you know, I think how people make choices and the care that they receive is, it doesn't matter whether that's in a hospital or outside of the hospital. It should always be within line with guidelines. The processes should be followed and everybody should be able to feel safe, whether it's a staff member or a service user, and their emotional well-being and the impact on them should be considered through that process.
Thank you very much. That's very well said. Thank you. I'd like to go to the portfolio holder now, Graham Oakes, portfolio holder for health. Graham, would you like to come in, please?
Yes, hopefully you can hear me and possibly even see me. My apologies for not being there in the thing. I treated myself to a nice holiday and I'm now having to catch up with tons of work. I wanted to ask a process question, and everyone's been very focused on where we are, and that's really good. However, I want to just look at the Yeovil maternity unit situation if I can. There was a CQC inspection carried out on the 10th of May 2024. And I think that what we were told at the beginning of this session was that 94% of the actions identified as a result of that have now been completed. Was that correct? Is this something you need a yes or no, really? I can't hear anything. Okay, for some reason, don't know. So shall I just carry on because I can't hear anything from the room?
Could you hear me now?
I can now, yes, wonderful.
Somebody's done something very intelligent with the technology. So the CQC action plan that I refer to in the paper and that I've spoken to is around the maternity CQC inspections that happened in November 23, and the reports were published in May 24. That's the action plan I'm referring to. So it's nothing to do with the paediatric services, which was the recent CQC inspection and the recent published reports.
Okay, so what can I just check so that was what I thought. So from the date of the inspection, it took 6 months for the report to be published. You'd have received a draft report, I'm going to guess late January, something like that, a factual accuracy element where you could argue the points. That's also roughly the point when you'd be asked to submit an action plan. Can you tell me how long were you given to create the action plan? And can you also tell me how long were you given to complete the action plan? Because I've been through many CQC inspections and I'm curious as to what's happened in this case.
I'm struggling to be perfectly honest. I'm struggling to remember the absolute time frames. Just to give you an insight, what happens after a CQC inspection, we have an ongoing relationship and regular meetings with our CQC, local CQC inspectors. And that conversation continues following an inspection where we inform them of progress and share drafts of an action plan over a period of time. So I'm struggling to remember precisely with this one. Sometimes, and for the other inspection, where we were inspected for our paediatric services, I think we were given a period of about 3 months to respond to a very specific requirement for improvement. That was a 29A improvement notice, I think. But the maternity, what CQC wanted to see is that we acknowledged that we had difficulties, which we did, that we got the gravity of it, and that we were credible in coming up with an improvement plan. And they, in a sense, monitor that and work with us all the way through.
Right, I think it was the fact that in that initial report, it said one of the criticisms was that the maternity services were not being addressed at executive board level, that there were problems with the learning culture and with some training issues. My concern is that the latest situation, a lot of that still exists, that the training issues are not, training is not being met to an outstanding standard at all. There's been improvement, but it's been improvement from a very low base. There's been a lot of discussion about the doctor situation, and I fully understand that, but I don't want that to detract from the fact that the other areas that CQC identified as long ago as November of 23, are only just being resolved or still not fully resolved. And I think it would be really helpful if we could have actually looked at the detail of the action plan. That would have allowed the committee to scrutinise it in greater depth rather than where we are at the moment, which is largely around how people feel about things are going at the moment, which is obviously a grave concern. Would it be something that going forward we could actually have come to a committee like this, whereby councillors could actually scrutinise, oversee what's going on with the action plan, because there's obviously new action plans in place now with the overall situation?
Yes, by all means, and I'm not sure, Councillor Oakes, but I think you might be, in some of what you just said, also mixing in with maternity the CQC inspection for paediatrics. And it is, if I may say, it can be really confusing because they are separate services, but there is an interrelationship between the way that they operate because the role of paediatricians. And I just wonder if it might be helpful to move on to a bit of an update in that service to try and explain that relationship. But yes, of course, you're very welcome to have the detailed action plan. We are very happy to share that.
Thank you. I think my understanding as well, Councillor Oakes, is the fact that you have been going through the action plan. You are telling us where you were, what you're doing now, what you want to do in the future. So I think although we're talking about it, we haven't got that assembled in front of us. I think we've got, many of you here in front of us now who will be able to answer those questions. So I think if that's okay with you, I think we'll move on, but I'll come back to you, Councillor Oakes, if you need anything else, okay?
Thank you.
Lovely to see you. Lovely to see you.
And you.
Thank you. Okay, members, anybody would like to ask, so I'll ask a quickie in between while you're thinking. The one thing that I had no idea, and forgive me, I had no idea about the care that's needed after maternity. That is something I hadn't actually thought. You always assume, being somebody that went through the fertility route and a very difficult time, and Musgrove was there for me in many ways and a marvellous job. But I had no idea. You sort of leave with your baby and you think that's it. But obviously it's not it. And I just wondered how because of the closure of the Oval, I'm just concerned about that. And the other thing I wanted to ask is, how are mums coping with this initial change? I know when I was expecting, I can still remember that fear. You're absolutely right what you said. I can still remember knowing that Musgrove was only 12 miles down the road. I could get there. We had no car, by the way. So, there we go, another problem. But I always remember thinking I was near enough. But I think the closure, I wonder what effect it's had on mums and how they've expressed that and how you've been able to help them with that.
If I'm honest, I think the thing that I've really struggled with in the role that I've done and the things that I've heard from people is how this initially landed, because one of the most important things is for people to have the information in a way that's easy to understand, that it's, gives you the what's happening, why is it happening, this is the information you need. Unfortunately, at the beginning of all of this, it wasn't, the information wasn't shared in the way that we spent sort of 24 hours trying to work really hard to get together. So what people were seeing was the news stories that I think created a lot of fear, and I had people contacting us really worried about what happens if I go into labour right now, how do I access triage? I'm really terrified, which wasn't a good start for people that are having babies right now. I think that one of the things that we've spoken about is if you live in Yeovil, you know where your services are, you chose to live there, which means that when you choose to have a baby, you know those services are there. And that's the thing that I think people are struggling with, is that now that choice and where they live doesn't have that service available. A lot of people live in other areas where the distance, the travel is a lot further, even for Somerset families. So making those informed decisions, having access to that information is what I'm seeing people are talking about is happening really well, that midwives are answering their questions, that they're able to have the information they need about transfer times when they're ringing triage. They're being able to come in as soon as they need to, being aware of that they might live further away, so let's not send you home, let's keep you You know, those sorts of things where if you're 10 minutes down the road from the hospital, you might go home and carry on walking around up and down the stairs and things like that. So I think that for me has been really difficult, is that people, and that continues to happen. I think that, you know, people need to access the information directly from their midwives, from the organisation, but sometimes the stories and the fear that comes out through social media, through media, that can be really hard on people. And when you're already scared about that precious life, you know, to have all of that information as well, like watching the news, isn't it? You know, the world's almost doomed when you see all of that information. So I think it's important to keep reassuring people that, you know, the staff on the ground are there for you, and midwives are dedicated to make sure that you can have the best possible experience. I'll caveat that with, you know, there's always improvements to be made, and women's health, the priority around women's health and supporting people to start, you know, the best start in life, and for people to be supported, having a family is so important, and that needs to be improved and prioritised in my opinion, to make sure that it doesn't just stop when you walk outside the hospital, and actually it probably needs to start before you're even pregnant.
And the aftercare, the care that some people need after, couldn't you just, because that has put pressure on Musgrove, obviously.
So our midwifery care hasn't changed. We continue to provide postnatal care. So after you've had the baby, both in the hospital and then when people go home, for a minimum of 10 days, usually it's longer. Sometimes it goes past the first month, and then we hand over care to our health visitor colleagues in the community. And the lovely thing, as I explained earlier, is that we try to have midwives, or a small team of midwives for every woman, so that they have some continuity. And, you know, one of the joys of being a midwife is looking after someone through the pregnancy. If you're lucky enough to be at the birth as well, amazing. And then finding out how it went when you go and see them in their own home afterwards, and supporting them into their new life as a parent. That's the joy of midwifery for me. And that's something that our team are really passionate about. And we have community midwives across the whole county who cover every nook and cranny, and make sure that people get that postnatal care in their own home, or in local hubs or community clinics, wherever the people choose to access care. So it's a tough journey, isn't it, into parenthood? Nobody can prepare you for this completely dependent small life, and we continue to focus on information and supporting women through that journey.
What I wanted to ask is a $100 question, really, is how long? How long before it's back to normal? How long do you think? Does anybody have any idea? And is this, if not, because I guess that's a really hard question, is this the right time for us to actually campaign for some support and help from Musgrove for the build at this time as well? Would that help the situation?
In terms of the how long question, Chair, some of those factors depend on recruitment and a ongoing process of improvement and transformation. But we are out to market at the moment to recruit more consultants. It's early days yet to conclude where we are with that, but Leanne might have more details. From our point of view, in terms of Musgrove and the condition of the building, it's always the right time, and any help is greatly appreciated. We were desperately sorry not to be in the group of hospitals that were announced a few months ago, and probably with lots of our other services we will get by, though it's difficult. But with maternity, it's a real challenge for the team.
I think we don't want you just to get by. We want you to succeed and do the job you do best. So I think that's for us. I think that's a real. So has anybody got any ideas? Well, Councillor Trimnell, I'm sure you have. Any ideas about this going forward?
Well, in terms of what kind of ideas do you want? Sort of, you know, a suggestion really on what we can do as a committee.
Absolutely.
I think is what you're saying. I suppose we could write to government, write to the Secretary of State and explain the situation, outline that we've now spoken to you twice. You've come before us twice now as a committee, probably going to come again, no doubt. And, you know, we're doing all we can to support you. Can the government do all they can to support you as well?
I know we have written once, as my colleague just said to me, but we can rewrite again and again and again. and I think maybe we can put this as a recommendation today. I think let's go forward and have a recommendation that this band of merry people that sat before us is going to actually see if we can help to make to make things better, because I think it has to be. I don't know how, but I think we can do that. I think we can go. Our portfolio holder might want to add.
I was just going to say that I do know that the MPs have been making a big fuss about this, and you probably know that as well. What I would like to know, because I know that quite a bit of Musgrove has been rebuilt, but it seemed to me that every time they do a rebuilding, they leave the maternity service out. Is it the last bit that needs rebuilding? I think it might be, or maybe it's not, but it'd be interesting to know, because I know there's a programme and there's been building work going on, and I'm afraid I don't know the details of that. But there has been some new building, but the maternity unit seems to be the Cinderella. It always gets left out. Is that right?
There's a range of buildings on the Musgrove site. You're quite right to say that. And at the moment, we've got a new surgical centre being built, which we hope to open later this year. This is really tough stuff. I mean, the planning of that probably goes back 6 or 7 years before I had involvement with the site. But what I can say about our current theatres is when it rains, we are operating and we have colleagues running around with buckets at the same time. So this is, it's that kind of, it's like saying, what's your favourite child, really? It's that impossible question that I think leaders have faced over the years. And then, of course, at different times, there's different amounts of funding for particular service areas. But there's no doubt that, and we're very grateful for any help the committee can offer. We're very grateful to the help that we've got from the MPs, actually. But there's no doubt that the absolute number one priority for the trust now is maternity. We are super focused on it and really grateful for any help that any of our colleagues in the system can offer.
Oh, Councillor Trimlow has put this proposal forward, and I'm sure that's what she meant to say, and I'm happy to second it. And we put this for recommendation that we actually take this to our executive to go forward to speak to send letters to our MPs and to actually push as much as we can, because I think there's no doubt about it. There is a problem here, and I think it's exacerbated by obviously the issues at the Oval. We need to get this done, and maybe this will give us the weight we need. So are you all in favour?
Can you just clarify what the recommendation is?
The recommendation is to,
Well, I mean, rather than writing to our MPs, I would include them, obviously, but
Yeah.
write to the Secretary of State.
Secretary of State.
I think that we need to go as far as we can. If we've been left off the list of hospitals that are due for work to be carried out, rebuilds, etc., then, we need to put ourselves at the top of the queue. You don't get if you don't ask, I think, is the problem, and actually almost demand. So write to the Secretary of State to request that due consideration and urgent consideration be given to the situation in Somerset Foundation Trust in terms of their maternity services, to provide the adequate facilities for both the Oval and Taunton areas.
Thank you.
Councillor Bruce.
I might add to that the letter might benefit from some sort of written report from our colleagues there in terms of actually what's lacking in the estate at the moment, the difficulties it's causing the team. But if it's possible to put something like that in a summary letter, there's probably a lot more detail there, but it might help to back up.
Yes, I think that would definitely clarify the major points about Musgrove that we're talking about at the moment. Obviously, we want the Oval, of course we do as well, and primarily if we can get the build for Musgrove, it will help the Oval until the times when they get themselves sorted as well. Sorry, Leanne, did you want to say something?
Just to say, as you might imagine, we've got a good number of such reports, and my offer was just going to be, if you do need to link in with us for any details to support your letter, then of course we're really willing and grateful to you for doing so.
Thank you very much. Max, is that okay? Are you happy with that? Are you happy with that?
Yes.
Everybody agree? Can we just show of hands? Everybody agree that we're going to go forward with that? Wonderful. Thank you very much. So what we would like is, I think as a committee, you've come before, we'd like you to come again. We'd like you to come back and give us an update report. I think Councillor Oakes especially would like that. And maybe you can let us know the timing which will be appropriate to you, 3 months or 6 months, whichever you feel.
Finish.
Yeah. They're on work program.
Oh, they're on the work programme for October. Okay, that's lovely. Just one. No, there's another section now. I just wanted to get that point sorted. That's what I'm saying. Sorry. I'm doing bits in sections so we don't get muddled. Thank you. Leanne.
Thank you. Yeah, it's very important not to get muddled at the moment with the various array of issues that all interlink with each other. So thank you for that. So just to be clear then, this update relates to the paediatric service, which was the service that was inspected by the CQC in January of this year. And the formal report was published a couple of weeks ago. So hopefully you have a chance to have a look at that. As you know, also we were here with you in May, just after having to make a very difficult decision to temporarily close the special care baby unit and therefore the inpatient maternity services on the Oval site due to safety concerns around that special care baby unit. And therefore today what I wanted to come and say is, you know, once again, we're really sorry for this situation. We really don't want to be finding ourselves in this place. I think it's really important that we emphasise that and acknowledge that. But what I would like to focus on today is rather than the reasons that took us to the closure, which we spent quite a lot of time discussing in the last meeting, just to talk a bit about the progress that we've made towards safe reopening of services at the earliest possible opportunity. So a little rundown of things that have been keeping us all incredibly busy in the last few weeks and months then. So of course, I think it's important to say that intensive efforts have been made to stabilise the current YDH paediatric service. So this service serves approximately 10,000 children and young people attending our emergency department. We admit then around 3,000 children and young people into our ward on the YDH site. And it's therefore really critically important that we stabilise and keep that service robust to continue to provide care for those children and their families. So that's involved a number of bits of work, which I'll kind of talk you through now. So we do now have, since last coming to talk to you, an increased number of our paediatricians, our paediatric most senior doctors, our consultants contributing to cross-site working, so working across both the Musgrave and the Yeovil sites, which is a really positive step forwards. And equally, we have now appointed a new Somerset Paediatrics Clinical Director who has been in post since the 1st of June. And I do just want to emphasise that rebranding of Somerset Paediatrics, and we feel that's really important for our future and the sustainability of services into the future. So this is about equity for everybody across Somerset, but it's also about creating an environment that doctors want to come and work in. An environment gives them a more diverse opportunity and ability to develop in their careers. Equally, we've now introduced dedicated child protection medical clinics. So these are consultant-led clinics. They are cross-county and they are reporting within our trust safeguarding teams. That's a really important step forward, particularly for our vulnerable children and their families. And very excitingly, this week, we've gone live with shared access to patient records. So one of our digital systems that was previously only available on one site is now available on 2 sites, which means that all our colleagues have access to patient notes. So cross-county and remotely, which I think is really important because that gives us some opportunities to work differently and improve equity. So, for example, if our colleagues at Musgrave have access to that information about our Yeovil patients, they can also provide advice and guidance from a distance, which is incredibly important as we move forward. From September, our Tier 3 doctors in training will be rotating between sites. So that is a real step forward in our education transformation to build a robust medical workforce for the future. So our doctors will spend some time at Musgrave and some time at Yeovil, and they'll be rotating through both services, which I think is a hugely positive step forward, and I hope you'll agree. The bit everybody wants to know about then, and to address Councillor Sally's question from earlier on around recruitment. So we do, hopefully you've seen, and hopefully you're sharing it very widely, have a live advert for consultant paediatricians. This is again recruiting to Somerset Paediatrics. So we're recruiting a group of colleagues, so hopefully 7, to really come in and help us improve and innovate services, a real group to drive that transformation forward. And I suppose the real bit that everyone wants to know is, you know, have we recruited anybody yet? So as I said, it's been live for almost 2 weeks. We have had some interest. And discussions are being had between interested parties and our medical leaders. So I think we've got some green shoots of possibility in here, which we're really excited about, but we won't have any further update on that for a number of weeks, because as you might imagine, there'll be quite a significant process around the recruitment. What else did I want to talk to you about? I suppose the other thing I just wanted to update you on is around, you know, that question around reopening of services. So this all relates to paediatrics, and if we get our paediatrics offer right, then that gives us the ability to reopen the special care baby unit, which in turn allows us to reopen maternity services. And so what we are currently finalising at the moment is a co-production with our partner organisations. That will include the ambulance service, 111, the local authority, Dorset County Hospital as well, a set of very robust criteria, safety criteria for reopening of services, so that we can objectively determine when it is safe to do so. And that will be fed into the 3-month review, which I know you'll all be aware of, which will be led by Somerset ICB. So I'm going to stop there. I'm going to see whether Andy wants to add anything to that.
And just a little bit, Leanne, I think just to emphasise the point that you made about increasingly we want to talk about Somerset services rather than YDH or Musgrove Park services. There's real strength in that from our point of view. We're going to be more attractive from a recruitment point of view, and also the services to have rotation across the 2 sites means that we've got a better chance of keeping everybody up to date with the very latest practice. And just that last thing is about, whilst we are reimagining paediatrics, the paediatrics, as with all our services in Somerset, we're looking at how we can make that a much more community orientated service, one that's delivered at neighbourhood level, rather than perhaps up until now that we do have community paediatric services, but they're relatively small. Most of our care is being delivered from the acute hospital sites. We want to modernise that, and there are examples in England of where there's a lot more work done in local communities alongside primary care, offering easier access, earlier access, getting to those families which perhaps traditionally don't readily access health services. We will take services to them. So that's all part of it. And, you know, sometimes out of these very difficult situations, there are good things emerge. They are a watershed moment. And I think that's what's happened for us with paediatrics and maternity and the knock-on effect. Really hopeful that at the other side of this, we'll end up with something better, more modern, and for many people, perhaps a little bit more local.
Thank you very much. Thank you. Any questions anyone would like to? Anything you'd like to ask?
Please, Chair.
Sorry, Liz.
Me again. So you spoke about making Somerset more attractive, a place to work. And unfortunately, I was getting myself a drink. And so I didn't hear whether I missed what it was that you're doing to make it more attractive, because we've spoken about this before. My son is a doctor. He's not coming back to Somerset anytime soon. And so how are we getting people to come into Somerset to work here? I'd be really interested to hear what that is.
There's something at the way you looked at me there, Leanne, maybe. Well, I think it's a competitive business, health recruitment, and you will know probably if your son's a doctor who will have incredible choice, no longer just nationally, but it's an international market for doctors as well. So we have to face facts that we're never going to have the same appeal for those doctors who want to work in a large teaching hospital where there are massive amounts of research, etc. You know, we're not that kind of service. We're not that kind of place. But I think what we're trying to do across a whole range of services and specialities is to play to our strength. So whilst we love dearly our acute services, and I think they're incredibly important, I spend every week in performance meetings with colleagues from region and they've got a huge national priority. Actually, I think for us within the trust, and I think increasingly our colleagues in the ICB and the council, we actually think that community and neighbourhood health is the way forward for us. We are almost unique in England as a foundation trust. There is nowhere else, possibly with the exception of the Isle of Wight in England, that delivers acute services, mental health and community services within a single organisation. We also deliver a quarter of primary care. We also work with a single council, a single ICB, which gives us great internal simplicity. And apart from the fact that it's a fantastic place to work and live full of lovely people, we think there are incredibly exciting models that fit with the 10-year plan. I've mentioned the 10-year plan before. It's a go for the executive summary. It's 158 pages, and I definitely recommend the 10-page version of it. But it is absolutely, I think it's got Somerset written right through it. The future for the NHS is being designated as a digital and localised neighbourhood services supported by acute care. I don't think you could design a plan that's better suited for Somerset. So I think we're going to look to position ourselves as being right out there on the cutting edge, doing new and exciting things. We'll appear in journals, we'll talk at conferences, and we've got to be better and we've got to be attractive. And I think we've got an awfully good sort of, product to sell really in terms of recruitment.
So build on that, Andy. So I was reflecting on something similar. We are uniquely positioned, as you say, as an organisation, and I personally think it's really exciting, and it's why I came to work here. I live in Devon. But I also think something else that we can and are starting to do, really need to do, is we're such a sort of a group of people focused on improving because we just want to be better and better. But sometimes we need to shout about what we're really good at to attract people. So, for example, we do have a CQC outstanding child and adolescent mental health service, which is completely almost unheard of in the country. And I think that's also how to bring people in. We're a very innovative place in Somerset, and there's a lot of very good, quiet work bubbling along, doing fantastic things. And we need to be better at celebrating and shouting about that to attract people to come and work here. So we're going to do more of that, aren't we, team?
I think you're absolutely right. I think that's what we don't do. We don't shout about the good, do we? We just look at the negative, and I think that's life in general, isn't it, really? I think we are a bit like that. I'm going to go back to our portfolio holder online. If there's no one in the room wishes to speak, I'll go to Councillor Graham Oakes, please.
Thank you, Chair. Can I say that the tone and the language and everything has changed so much over I'm not sure how many weeks it's been now since we had that crisis day in Yeovil, and it is so pleasing to hear the talk about a Somerset approach. I really welcome that because I see flexibility of staff working across two hospitals was what we were promised, and it would, had it been able to have been in place, would have meant the MAT unit wouldn't have closed. Can I just check one thing? There was something that was actually, I mean, this may be incredibly dull to everyone else, but quite exciting from a nursing point of view. It was said that the access to notes now is available. The Musgrove site notes are available in YDH and vice versa. Is that just in paediatrics, or is it across the whole piece between the two hospitals?
So, Councillor Oakes, I can talk about my part of the world in the hospital, which covers children, young people and families. So, and my understanding is it's a system called ePro, and we have this in Musgrove and we've rolled it out to YDH. So certainly for paediatrics. However, I'll pass to Andy to talk more broadly about the future of sharing of patient notes.
Thanks, Leanne. You know that territory where you're kind of thinking, am I at the right side of press releases here, or am I speaking ahead of things? I don't know. So I'm just going to chance it because it's good news, which is, thank you, Leanne.
Hey,
I owe you a hospital pass, I think they call it in rugby.
Can you give it to me, please?
So only last week we had confirmation. So I'll just ask, to put this in context, but we had confirmation that something we've been pursuing for a number of years now, which is the funding for a single electronic health record. Do you know where I am with this, David? Am I in safe territory or not? Okay. I was just about to caveat it with, we are hopeful. So just only last week we had confirmation that we have now got the funding for a single electronic health record for Somerset. It's a piece of work we're doing in partnership with Dorset, actually, having been encouraged by the Department of Health to spread the costs over 2 systems to make it affordable. These incredibly expensive systems, but absolutely cutting edge. So at the moment, as a trust, believe it or not, we've got about 600 data systems. We've got 3 main patient administration systems, which don't fully talk to each other. And this will give us a chance to bring in a single electronic health record. And because it'll be state of the art, it'll also seamlessly integrate with new technologies like digital voice. So, getting away from our colleagues having to record with pens or on letters. They'll be able to speak it. The records will go through. Ambient voice technology is just phenomenal. It's so exciting if you've ever seen it. And some real productivity and efficiency gains as well. So hugely good news. It'll take a couple of years to get it in because they're very big projects and we'll need to go through a tender process, etc. But really exciting stuff for Somerset and another piece of the jigsaw about why we are going to be great.
Good. Councillor Pearlstone.
Oh boy. Approximately 20 years ago, I was made aware I was waiting in a waiting room reading Computer Weekly about how the NHS was going to integrate all of its digital systems. And I believe that that has been continuing for the last 20 years. And I will mention the fact that I believe that it was Fujitsu that were undertaken by the early Labour government of 97 to carry out this work. Why now have we got this yet another system, which I agree, fabulous news. What happened to the system of national integration of digital that's been going on for what seems like forever in terms of computer reprogramming and software design? Thanks.
I've gone right back to physics too. That's incredible. Yeah, absolutely. It has been around for some time. And there's a number of strands too. Andy's touched on the 10-year plan that came out last week. And there's a number of strands to that. One is trying to ensure that all the activities that go on within the system are captured. So at the minute, some areas have got that on paper, some have got it on a number of a plethora of digital systems. So there's a big drive to digitize everywhere, so you've got it in digital format. There's now a big drive around trying to ensure that the architecture that's out there is personalised to the individual. So building around the NHS app and seeing that as a true front door to the NHS. And the 10-year plan itself sets out various modules around what capability members of the public will be able to access through that app. So sitting behind all of that is how you join the data up. But you need systems at big providers like SFT to be modern, up to date, and comprehensive, and that's what they're looking to procure now, because the data that captures then flows its way through into the app and into the individual itself. So it is, there's a number of, I could talk all day, I'm very happy to catch up outside, but yeah, so no, it is, all this requires money, and I think that's the funding is the unknown at this stage at the national level, but certainly the plan is there to try and join up the systems, but you need systems in the first place to join up.
Just to come back briefly then, so you're looking at a plan for Somerset and Dorset. Obviously, it's almost like an overwrite of what's been going on for the last 20 years due to technology moving so quickly and being able for the end user to be able to access it through app systems, which wasn't available when they first started trying to put all these systems and digitise the system together. So how will there be a guarantee that as an end user in Somerset and Dorset using certain systems that other foundation trusts, should you go on holiday, for example, are integrated with the Somerset Dorset system. I mean, if they're not doing it, but we are, how, again, it seems like the same process that can end up getting caught up again and again, because not everything is done at the same time in the same way.
Yeah, sure. So, I'd say I'm very happy to go into detail outside, but yeah, there's something like kind of national interoperability standards, so that each of the systems that people are buying speak to one another. And then there's another strand, I've mentioned the NHS app work stream, there's another strand called single patient record, which is just being scoped at the minute, which would enable an individual's care records to be accessible no matter where you are in the country. And so build on the summary care records out there at the minute. We're very happy to catch up and go through that.
In that case then, excellent superb news, nice to be exclusive.
Thank you. I think we all agree that shared data is something we've been gone about. This government, past government, the one before, you name it, we've been talking about it for that long. I was young when we started talking about it, so it's really, really excellent news. But we can't scrutinise that because it's not here yet to scrutinise it. So, you know, anyway, okay, we need to wrap this up because we're an hour over today, but it's been very interesting. But Councillor Bruce, go on.
Yeah, just a quick one. So I just wanted to clarify, the funding that you've confirmed has been received now is just for the system for sharing of data internally. That won't actually bring it to the end user through like primary care. So connecting up what the GPs can put on the NHS app and what the patient can see from the hospital or the GP. The funding that you've got is just for internal sharing system, or will it also come through to the app? I'm not clear on that, sorry.
You want to bring that up, John?
Oh, I'd be so grateful if you talk about this.
So, the funding is to have a comprehensive system. So as Andy's mentioned before, the trust is a provider of acute mental health, community services and general practice. So the system itself enables that information to be shared well across those clinical teams. The general practice bit is slightly out of scope at the minute because no vendor in the country provides a system that does all of that. So that's the scope of what is being or what will go out to be procured. We have got mechanisms in place already through the Somerset Share Care Record that does share some information across providers at the moment. And we are seeking to align that and integrate that with the NHS app. So you will be able to have some information into the NHS app through that shared care record. It gets quite complicated in the architecture, but the core part of the bid, the funding bid that the trust has been successful, is that clinical system that joins up the services that they've got responsibility for providing with the sort of general practice element to follow in the future. Okay.
But I'm hoping that we call you back in very shortly when this is all live. We call you back in to scrutinise this, okay? And then we will know how well it's doing and how good, and you'll be able to come back. I'm going to give the last. Councillor Oakes, did you want to say the last word? We need to close down, so I'll give you 20 seconds.
Okay, on Monday I was in Egypt when the internet went down, and I mean it went down for the whole country. It was an absolute nightmare. I've used the systems, not the premium ones you're talking about, but voice activated or this sort of stuff. And I'm a big fan. It's made a big difference in social care. My only concern would be, having seen what happened to a country because of a fire in one building, we need a way of protecting so the system stays live, rather than having to wait till it comes back on and sync notes later, because it's not just about recording care, it's about accessing that data. And one of my residents this week in YDH suffered because they didn't have this system, and there was a direct consequence for him. So we need a way of having this system, but we also need to have a way that protects it. And I don't actually know what the solution to that is, but I just need to say that's the big worry of it. The rest of it is fabulous. And I'm as excited as you guys, even though I said it was dull. But for people like me, it's not.
Now, please. All right, we're on record. I'm going now. Thank you. All right, thank you, members. Thank you for that short break after an excellent morning so far. Item 7 is the NHS performance report, which is pages 41 to 52. I'd like to invite David McClay to present, please, and we'll ask questions of you after, if we may. Thank you very much.
Thank you, Chair. So yeah, I covered this for Michelle. I'm just going to take you through I wasn't going through it line by line, but I'm happy to take questions and queries. And if I I don't know some of the detail. I'll get back to it outside of the meeting itself. So just to explain the report, that it's an exception report. So we talked in the previous item about always focusing on the negative, and this report does that. It focuses on the things that are kind of running out and are slightly out of kilter, and it separates that in the usual chunks that hopefully you'll be familiar with. I'm happy to take some reflections today on the report. If there's anything in there that people feel needs to be kind of further developed, or anything that isn't in there that people would like to see, because we're always keen to iterate and to improve it. The key chunks that it pulls out, it relates to sort of performance across March and April, which, as you know, is for us is sort of the end of the winter period. The first section is around urgent care. We're in the midst of planning for next winter at the minute, ironically enough. Sort of 25 degrees outside, and we're knee deep in winter planning, and that goes in around trying to enhance the proactive care that's available for people within general practice, as well as the number of steps and measures that can take place within the trust itself to improve processes, etc. So that's kind of our current focus, is in looking ahead now. So when we come out of the summer period, how do we make the system more resilient? So that would be seen in that sort of 4-hour performance target and improvement against that. We touched on earlier the non-criteria to reside and the steps being taken to improve the alternatives to bed-based care. We had a session with this committee about 3 or 4 weeks ago, which hopefully went through that intermediate care work jointly between the council and health in detail. And that's still a challenge. The trust have done a lot of work. It's reflected in the report to try and reduce the delays that are on their side, if you like, if you look at it that way. How can they improve the steps they take and the flow of patients through the acute environment? And that work is making good progress at the minute, and the numbers are in there around the reduction, trying to get right down to circa 20 days. So that is a key piece of work for us for the reasons that we spoke about in relation to the question that was asked earlier. We need to develop robust, resilient alternatives to bed-based care across the different pathways, and that is a key focus, as I've said. The other bits then are around elective and elective waiting times. There's been an ongoing programme of work to try and improve the process that's is applied and the steps that patients go through on various pathways within elective, and that's kind of there's a whole ream and a programme plan that sits behind it if people are interested in seeing that. And there's also work being done at the minute to validate, if you like, the waiting list and how accurate that is. And every trust and every big provider across the country would do that periodically, make sure that the data that's held, the listing of patients is correct, and that's been work that's recently undertaken by SFT. We're also working with them from an ICB point of view and looking at what the future looks like on electives. So what capacity do we need, and how do we start to move away from just looking at people predominantly with regards to waiting time, and start to play in other socio-economic factors and health inequalities factors. So you look at the list of people in the round and focus in on that as well as the wait. So I'd say that's kind of that strategy work is in development at the moment. The last section we've got on there is around talking therapies, and as you can see, there's been a challenge around the gap between first treatment and second treatment. That's currently running out, maybe due to the complexity of cases and the cases not being appropriate and suitable for group work, and with additional resource that resource is now being recruited to, and that should see some improvement in that over time, but it is a challenge as of today, as it was at the end of March. So I'm happy to take questions. I was going to propose in terms of that winter plan, I think it might be of interest to the committee. I appreciate we've got constraint for time at most of these meetings, but when our winter plan is developed, we've got to have that in place for challenge by NHS England in September. So I'm very happy to come and sort of go through that in a bit more detail for people, because it does break down how we're improving the resilience within general practice and how they get ahead of the game and ahead of the demand curve, as well as the interface between general practice and the acute, and then all the steps that the acute are taking. So I'll be happy to come back and talk that through around urgent care. I'll happy to take any questions today or any queries we've got.
Thank you, David. I've got a couple of questions, but I go to my, the one thing I would say to you, it's not, you didn't write this report. No. I didn't realise that the NHS were part of the SAS now. I didn't know that TOCCH, there's lots of acronyms in here. Some of them I was able to find, but some of them I wasn't able to find. And I spend most of my life going through and thinking, what is that? And most of them are in you've got them in bracket, they're in brackets. Yeah. But I would, you know, urgent treatment centres, that was fine. But I couldn't find the SAS. I'm sorry, I couldn't find it. And it's just difficult sometimes when you're trying to understand. But I have got another question, but I'll leave you with that thought, and then
Yeah, sure. No, happy to go through it and yeah, plain English. I think that'll be helpful.
It would be.
Yeah, and as I say, I'm happy to take on the various queries on the scope of the report and what it covers, because I think there's other stuff we could bring into this.
Yes, certainly.
As well.
Okay, Councillor Trevor, please.
Thank you. So on a similar line, I found this report was really, I hope high density would make, so there is so much information in every paragraph. I found it quite hard sometimes to read. I felt as if I'd had time, I would have wanted to make notes and list things or put them differently. And I don't know whether there are other ways to display that information or just explain things a bit more. And it's not a criticism, but I think it's probably been written by people who understand it, and the people who are reading it don't necessarily understand it. And I think that was, and your icons and your graphs, I couldn't work out whether they were, you know, there's no median, but were they into quartile ranges or something, like there were dotted lines, red lines, black lines. I couldn't figure them out.
Yeah, listen, thank you for that. Apologies for that. Yeah, I think it needs a bit of work. It's a lift from a report that goes to our board, but for our board, we do training sessions in statistical process control so that they can kind of understand it, interpret it, and there's probably a bit more backing to it as well that explains it all. So I'll take that away and work with the team. You're absolutely right. It's been largely prepared by the kind of performance and information team. And I think there's a kind of what is the story that it's telling is the bit that would be helpful to draw out for the next time we bring it here. So, so thank you for that.
I have another question.
Oh, sorry.
Sure.
It's only, well, I hope it's a short one, but I wanted to just have a bit of an outline about the partnership between adult services and the ICS, because you're working towards the same thing. And I kind of felt as though it was a bit like the Channel Tunnel, where they worked from different ends and they met in the middle, but that was an engineering project and they were a millimetre out or something. But we're working with people, these are human services. And so I wonder how that works, because you don't have the certainty of maths and exactness behind you. So how are you overcoming any challenges?
With regards to adult services?
Yeah.
Do you want to pick that up now at all?
Yeah, no, I'll happily do that for you. So intermediate care is often where we meet together, and actually those services are commissioned together. So it's not as though you've got one person doing it and the other, and actually they work as a team. And I know we had some information around intermediate care in the workshop.
We did, yeah.
And as you saw there, that was a joint piece of work. So I think that's the bit for me. It's about how do we join up together. So we work really closely with each other, whether that be with our primary care services, through our GPs, or through others. It's about how do you collectively work around a policy. Now, that doesn't mean to say it's always seamless.
No.
We do our best to do that, but it isn't always seamless, and occasionally we don't get it right. And that's the working that we do together. So we have something called the Better Care Fund, and the Better Care Fund is a pooled arrangement, and that we look at, the metrics are on there, so we understand what we're looking at together, and we work together with the ICB around that and report together.
That's brilliant, thank you.
Yeah, there's a lot more sharing of information, and as I say, we've got oversight of that Better Care Fund through joint governance arrangements as well. And yeah, there's always there's areas that the visibility in the relationship that's improved and strengthened. There's always areas that we've got individual positions on, but yeah, I think it's certainly from our point of view, it's fairly well joined up. Not all the time, I appreciate it doesn't. It could be improved, but yeah, the systems are in place.
Thank you.
Thanks.
Thank you. I'd just like to mention, while we're waiting for people to come up with some, on the page 43, we're talking about accident and emergency 4-hour performance. I know you're only doing it on a 4-hour performance, but have somebody who spent a bit of time at Musgrove recently, you'd be lucky 4 hours report. You know, I mean, I sat in there for 7 hours and still didn't get seen, and it was absolutely chock-a-block. Now, the thing I wanted to bring to this may not be the right format, you know, so forgive me.
Sure.
I feel that they're working under extreme duress at Musgrove. And it feels to me like there should be a filter system. There were people sat in there that could have actually gone to a chemist, could have gone to a doctor the next day. And there were other people in there bleeding, holding their heads. There seemed to be the organisation The other thing I didn't like in there was that people were being seen and being triaged in front of everyone else. They were sat at the side of the desk having to talk. I know this is not what we're talking in a sense, but what I'm trying to explain is the whole mechanism in our A&E is wrong. Somebody needs to sort it out. They need more staff all times. I mean, apparently I've been told, do not get ill on a Monday night, because Monday night is the worst time for being ill at Musgrove, because people have had accidents over the weekend, waited till Monday night to go on to work and then gone to Musgrove Monday night. Monday night's their worst night. I mean, it's just horrendous. And there was big things in there and small things in there. And I do think that organisation of the A&E really needs to be really looked at. And I'm saying this for the staff, because I felt so immensely sorry for people. Some people were very, very unhappy, being very vocal, and some were being, and the ones that were worse were being lovely, and the ones that didn't have much wrong were being vocal. So I just think we need to, but I mean that's not as a criticism. I mean it as a point of help, if I can say that.
Yeah, sure, and hats off to everybody that works in the department, because it is a pressured environment, and you're making decisions constantly through the day. And most departments would be like that. To be fair, we looked into, you mentioned previously the triage in an open space, and they've assured me that they don't do that. It is people being registered and having to explain a little bit about what is wrong with them. But we're happy to pick that up.
Well, I can honestly tell you, it was being done all night long.
Right. Okay.
All night long, they would be. Some people had very personal things. They had to sit and talk in front of everybody.
Yeah, so happy to pick that up. Yeah,
thank you. Thank you. The other point I'd like to mention, if I'm here, is the SAS post. Do we know what that was?
I'm trying to find it in the paper. Yeah.
It's on page 44. Successful and ongoing recruitment, including consultant and SAS posts, pending re-employment checks.
I'll find 42 and come back to it.
44, page 44, sorry. So it's about ongoing recruitment. And I noticed that you said about the number of emergency admissions where the patient has a lengthy of stay of 1 day increased by 3.3%. So is that why they're being that's at the AMU, isn't it, where they're being investigated?
Yeah, that's right, yeah.
Yeah. So does that work? Does the AMU work?
Certainly, yeah, like all these things, it's it's under pressure at different points of the week. But certainly the feedback we've had in general is that it's well received, and it does provide that ability to pick up demand that otherwise would be gone elsewhere. So yeah, I'm happy to again look up outside of this.
Yeah, no, I went to AMU, and I'd have to say it was looked after very well.
Yeah.
But there was a number of people that didn't have the same response. So there was just those things, and you don't know what TOC is. TOCH. Transport. Yeah, of course it is. Sorry, I'm stupid. Sorry, apologies. So sorry. When you're trying to understand, I think Councillor Trimlin was absolutely right. This is a very detailed report, and it's. I like the graphs, but I need to understand the graphs, and I think I kind of got them. I kind of got to the point where I did, but I think what we need to do for the layperson, with the greatest respect to us all, is have perhaps a little bit more normalised with that. I think that would really help us, you know what I mean?
Yeah.
But I do like the fact that you've given us the actual data. I think that's very, very good.
Okay, no, thank you for that. I think there's something about openness of the data so that people can go in and see that. But I think this painting the story and we'll tell the story and painting the picture that we could do a bit better.
Yeah. And could I finally ask you about the waiting times for the cancer waiting times? It says a 62-day combined cancer waiting time. Unfortunately, I joined that club many years ago. And it was 21 days. You had to be seen in 13 days. You had to be seen and diagnosed. Now, my pathway was slightly different, but I noticed it says 62 days. Is that just the journey that you've done there, or is it?
Yeah, so that's the one we focused in on. There's still the 2 week waits, which is what you're referring to. That's still in place. There's 31 day and 62 day standards as well.
62 days?
Yeah, for that. I think that's first treatment to commence.
62 days. It seems a long time to me.
Yeah.
That seems far too long to me. Sorry.
Oh yeah, it's not the initial assessment. The initial assessment and the 2 week wait is still there.
Yeah.
It's like first definitive treatment.
First definitive treatment. Okay, thank you. Mel, sorry, Mel.
Sorry, maybe really helpful. I know you've done it in the past. If you stick some benchmarking data in, because I think the graphs at the moment show Okay, but does it tell us whether this is good, bad, or indifferent?
Yeah.
I agree.
I think, even if it's a rag weighted, I think you could just simplify it a little bit more
Yeah, no, I
going
agree.
forward. I think that'd be easy for people to, and what, because this is a public document, so the public will read it. I'm not going to necessarily work that through.
Yeah, no, fair enough.
Yeah.
And I think we're always worried as well that the public will get the wrong end of the stick. I think that's another thing, that you could be reading this and feel, actually, it could be really good, but we've got no comparative. And I think that's what I would like to see as well, if it's okay.
Yeah, sure.
Would that be all right?
Yeah.
Thank you. Does anybody else have any questions, please? No? Okay, well, thank you very much for that. Apologies if we sound a bit negative, we don't mean to, sorry.
Right, no, listen, when I read the report myself, I thought it needs a bit of work to sort of bring it.
Unless we need a bit more training, sending us in, maybe we need that, maybe that would help. Anyway, well, thank you very, very much, David. Thank you for coming today.
Yeah, no problem.
Thank you.
Thank you.
Right, the next item on the agenda is the adult social care performance, and John Hatfield. Welcome, you've been waiting a while, John, so I'm sorry about this. And, so over to you, John.
Can I just say a couple of?
Oh, I'm sorry, apologies, sorry.
Thank you very much, Chair. Just wanted to say that this is just a snapshot of what's been going on, which I think has been asked for, and rightly so, by the committee to have this introduction. I just wanted to say, I'm sure you all know, but the front door demand is this people ringing up and saying, can you help me in getting triaged across to adult social care? And it is really important that people do get that advice right at the front of what they're experiencing, so that they know. And if somebody was immediately somebody who's going to need to have a care act assessment, that will be picked up at that point. It might be that they will be sent to other people, village agents or whoever it is, or just somebody to go and visit them, or given advice about services, or even sent to one of our Somerset independent living centres. So I just want people to be absolutely clear that we're not saying to people, you can't be seen. We are saying, what is the nature of your problem? It's not like when you ring up the GP, actually, try and get an appointment, and they ask you a bit about the nature of it. So that's working well, and you'll see that the figures are quite good there. And the other thing I want to say was a bit about the Care Act assessments, which have been going down, doing a lot of work in that, but I thought I'd mention about the reviews. So when you have a Care Act assessment, you're supposed to have, well, the idea is that you have an annual review. And that is really because your care needs may have changed, and there may even become less rather than more. If somebody's come out of hospital, you may need less care. So that's for us and for the person. And there are overdue Care Act reviews. They are important, but usually if the thing has got far worse quite quickly, they will be in a different situation. They won't be waiting for a review if they need to go to hospital or if they need further treatment. So it's a good way to behave. It's a bit like some of the things that come at the hospital to review everybody every year, which we try and do, but we are a little bit behind with that. I just wanted to say those two things.
So in a way, what you're saying is once we're in the system, we stay in the system, and then we're sent to the right. So if our care needs change by yearly, then we're not going to start all over again. We're just literally filtered to the right area. So I think that's pretty good. Everybody understand that? I think that's pretty good, isn't it? And because it's always a weird fear, isn't it, that you're going to have to start the whole process again. Okay, thank you, John. Over to you.
Thank you. Just by way of introduction, I'm John Hadfield. I'm a service manager in adult social care, responsible for policy, performance and assurance. And I'm here today to do the regular quarterly update on adult social care performance. And I'll just step through, I think we've got 6 or 7 key kind of performance areas, and I'll just step through those on the slides. Happy to take questions as we go, or to wait till the end, that's fine. So we're starting with the front door. So just for context here, our target is 60%. So we aim for the customer contact centre to resolve 60% of calls that they handle at that initial contact, without needing to send them to one of the social care triage teams. In the whole of 24-25, our performance was 59.8%, so very close to that target, but just below it. So far in 25-26, so for the first couple of months of 25-26, we're at 60.3%, so just over target. That is admittedly on a slightly lower average call volume per month, but even that is approximately 5,000 calls per month that they're handling.
Can I just add that when they spoke with somebody like that, they do some sample callbacks to see a few weeks later to see if the person has got what they needed. So that it's not a huge amount, but they do some sample callbacks of the people that ring in and get dealt with, so that we're not just saying you're out of the system again. So there's a bit of that going on. We need that feedback.
Yeah, it's good. Yeah, good.
And just following on from that, we're also doing some analysis at the moment of people that call back multiple times in a short space of time. So actually, was their call resolved, or did they need to contact us again? It's relatively low numbers, but it's important that we understand that.
Can I ask as well, there must be difficulty, when I spent the evening I felt the day in hospital, the evening rather, I spoke to a young man who was unkept, uncared, and, well, he wasn't young really, but I thought he was. I felt the difficulty. He was telling me how difficult it is. He's getting special care, he's getting special this, special that. But I did wonder, how does that work when you've got difficulty with people with speech, difficulty with expression? How does that work? Sorry, Mel.
It really depends on the individual. We don't just have a phone call where somebody can, it is about having multiple channels, isn't it? And later on, when we talk through talk through our inspection details for you, you'll actually be able to see there are drop-ins all over the place. And I think it's about actually having the drop-ins available and being aware of those so that they can go and see and seek. Because actually ringing a number sometimes is absolutely the wrong thing to do. If they've got a learning disability, or if they are mentally ill health problems, so that their mental health is deteriorating, again, there are other places to go to. And I think that's the challenge for us. There's many front doors. What we're talking about here is the main front door that we have as a service.
Yes, it's the main front door I was talking about, the people that don't leave their homes. That's what I was trying to say. And sometimes they don't always express themselves. And I was just wondering how you get the right information, but that's what I was trying to explain, sorry.
I'm sorry, some people will approach adult social care through A&E. I mean, and if that's where they need to go, they will help them with that. They will get in touch. I mean, it's not a unbroken thing. They will do that. So you're absolutely right there. There are people out there who are being missed out by all the systems that are in place. But there are also people who don't really want to engage.
Yes.
And that's a really big task for us, certainly with our homeless, to actually get them to engage with us. We have got outreach workers to do that. It's far from perfect. I would absolutely say that it's far from perfect. But that is because we have so much choice in society about how we live. And that's what we want. We want people to have choice, but you can choose not to engage. And that's a really difficult problem for us, actually.
It is.
Okay, if I move on to Care Act assessments. So Councillor Wakefield touched on this one. So just to clarify, what we're talking about here is Care Act assessments that have gone beyond our 28-day target and where they've not been allocated to a named social worker. Slide's a bit small, but the initial number on the far left-hand side was just over 600. We're now at just under 200. So we've reduced by about 70% since April 24. Clearly, the nearly 200 is still too many, but that clearly shows that the trajectory is going in the right direction. And for context, that means that between April 2024 and March 25, the teams did nearly 5,400 Care Act assessments with individual people. So that's about 450 Care Act assessments per month. Which is, quite a significant productivity increase compared to what we've seen in previous years.
Move on. Are we taking questions in the middle?
Certainly, I apologise. I was reading. Sorry.
That's all right. We're a bit shy of mics. Oh, is that one? Come on. Thank you. With the Care Act assessments, first of all, well done, because I remember seeing numbers along with the rest of the committee that gave us all quite serious concerns about how those numbers were going to be reduced. So the current number of just under 200, I've seen previous examples of this graph with multiple threads of risk, I suppose, to whether they are, or how long they've been waiting. That was what it was, how long they've been waiting. Can I ask if the 191, sort of what, is there a breakdown available for how long some of those 191 have been waiting? Thank you.
There absolutely is, not in this slide pack, but I'm happy to share that. And actually, we're starting to look at a new performance framework with some new measures. And one of the things that we're going to include in there is around timeliness. So it's not just a number, because it could be 195 that have been waiting over a year, or they could have been waiting a week over the 28 days. So that amount of time overdue is real context that we need. So that will be, I can share the numbers for this, but absolutely we'll include that in future.
I think what we're going to do in future, what you'll see is that nobody should be waiting over 3 months, and that figure will be 0. So over 3 months is where we're going.
Really impressive.
Now we're not there for, we're not there yet for over 3 months, but that's where our aim is to get to over the next year. So that's what we're sorting. And Emily, hopefully, no, she hasn't got it up yet. Yeah, she's got the data up. I thought if I took 2 seconds longer, she'd be able to give you the data.
Yeah, I look at this data every single day. So it's the first thing that I do every single morning. We know the 2 individuals that are waiting the longest amount of time. We know which service area they're in. They're both individuals with a learning disability. And this is more to do with the validation of recording rather than anything else. Our next individual that has been waiting is a 50-year-old gentleman, but I can see from the records that we've been in regular contact with that individual as well, and they've also got links in with the community agent. We've got something that we call waiting informed, so we make regular contact back with everybody that is waiting for a Care Act assessment. So we're making sure that their needs are being met. They're being supported through with community agents, and that then we also look to see whether actually the risks are increasing, so we need to reprioritise individuals as well. We've got a breakdown in terms of the targets. We are looking at nobody waiting for more than 3 months. I think at the moment we're about 30% of individuals are above that 3-month target out of interest. So the teams have worked tremendously hard, and they've been doing various different things. Just, I know some of you may be thinking about, actually this is about getting numbers down, and what about the quality of the work and the practice that's happening. We do have a practice quality board, so we scrutinise all of our Care Act assessments as well, so that we make sure that we're working in a really strength-based way, that we're really gaining the viewpoints of the individuals, and we're not rushing through them. So we're not hitting a target rather than getting that quality there for individuals as well. So we're maintaining that quality, but new ways of working have improved things for our workforce as well. So which has then seen the increase in our productivity.
Thank you very much. It really is quite something to see. And can I ask, just on the back of that, the staff that you have now that are going through all these processes, are they content and happy? Is it improved, staff morale and workforce dynamics?
Nobody wants to come in and look at a waiting list and thinking, how am I going to get to see those people? That nobody came into adult social care to do that at all. People want to be spending more time with individuals, with people, having those conversations and trying to identify the right solutions for them. What that people are seeing now is that actually the impact that they're having on individuals, so that productivity is increasing, and it is, we've still got a long way to go. Our reviews still remain quite a challenge for us. But yes, there is much more job satisfaction there for individuals, which is a real positive.
Thank you.
Over to you.
Yeah, Emily just mentioned reviews, and I may well hand back to Emily if there's something she wants to say about reviews, but it's not quite the same positive story as with Care Act assessments, but there is some work going on, and actually what we found with the information that we've submitted to CQC ahead of our on-site visit, whilst they're interested in waiting lists, and I think every council has waiting lists, they're not just interested in the numbers, they're interested in our risk management approach. So do we know who's on the list? Do we know the risk profile of those people? And are we keeping in touch with those people, as Emily just described, around assessments? So there's some focus work going on at the moment around making sure that we can do that for reviews. I don't know, Emily, if there's anything you want to add to that.
Yeah, we've got a plan that is being, well, we've got a review trajectory across each of our teams, and that slightly differs between teams. So for our mental health team, our learning disability teams, and our neighbourhood teams, we're working with our providers as well. So because they're seeing those individuals day in, day out. So we're looking at our trusted provider reviews as well, and how we can then validate those and ensure that we're working in line with our Care Act duties. We've got a monitoring and an oversight board that takes place on a fortnightly basis at the moment that reviews in terms of the data. I mean, we're still doing, so it's about just over 400 reviews. You add that onto the Care Act assessments, there's a significant amount of work that is being undertaken. We are looking at the review data at the moment because there are some individuals that are getting more than one review in an annual period. So we're just looking at some of that review practice at the moment for individuals, and we're targeting some areas of where we know that we need to do a bit more focused work on the practice that is taking place.
Can I ask you a question, please? On the reviews, you start off, you've got, say we go from January 25, you've got 3659, and then you go to 3714 for the next month. And yet down here it says from April 24, there were a total of 4,838 reviews. What does that numbers equate to there at the top? Is it just something different, or is it?
Yeah, so sorry, the numbers in the chart are the number overdue. The number in the table at the bottom is the number that were completed. So it's.
Oh, I see. Sorry.
It's going up, but that's not because we're not doing reviews. You know, we're doing, as Emily said, just over 400 a month on average, and yet that number overdue continues to increase.
I see. Sorry, I can see that now. It's quite plain. So sorry. Councillor Trimnell.
Hi there, thank you for this. So I just got a question. So it says that approximately 403 reviews have been completed a month. It also says that ongoing internal workforce pressures are contributing to the difficulty here. So what I wanted to know is, who are you looking for in terms of trying to fill those vacancies, and how many would you need to be carrying out each month to be able to hit the target, to be able to bring down that number and then keep on top of it?
So we continue to have workforce pressures across the teams. Our main vacancies are with our social workers at the moment. We've done a significant amount of recruitment. And we welcome 5, I think, international recruited social workers to Somerset this week, which is fantastic. We still have got some workforce pressures, but they are, our workforce is increasing, which is brilliant, but it's also then the training that then needs to take place and everything else as well. We've got some areas that are more impacted by others. So we are, our main recruitment areas that we're struggling with are over in the east of our county. And we're working with our recruitment colleagues and HR to look in terms of how can we best support those individuals. In terms of review trajectory, Lucy, it's slightly different for different areas. So for our mental health teams, because the cohort of individuals that they're supporting is very different to, say, our learning disability teams and our neighbourhood teams, each area has its own trajectory. We can bring that information back to you. But yeah, I mean, we will always, it's about the review practice that we do. So we're sticking to those annual reviews. And then for the larger teams, it will then depend on whether people need reassessments or not, but we've got a whole trajectory that is specific for each area. So it's not a one-off number, if you like. So it doesn't really answer your question, but we've got that trajectory that we can definitely share with you.
Yeah, no, that's brilliant. Thank you.
It is worth saying as well that the assessments that we looked at previously in the reviews, there is a link, because obviously the more care act assessments we do, that then generates, if it results in a service, a forward review for that individual as well. So whilst the increased productivity in assessments is great, it adds to the demand around reviews as well. So it's sort of a double-edged sword. Okay, if I move on to unmet need. So this is where we're trying to find domiciliary care for people following a care act assessment. They appear on the unmet need list if after 7 days we've not been able to source that care. Historically, and the chart looks slightly odd because we've got these sort of black and red and amber and green sections. Everything you can see there is right at the bottom of the green. If we went back about 18 months, we were dipping in and out of the red and the black sections where there were challenges with the market. Actually, you can see this has really settled down, and at any point in time, there's generally not more than 1 or 2 people where we're waiting for dom care.
I think in that space, that's why when we talk about how do we model a system going forward and do we need as many beds, the answer is we've now got a stable market. So probably not those beds in perhaps our community hospitals, etc. And that's one of the things that starts to help us do this. You will start to see that we're going to take this off. You're reporting, unless it becomes a trigger for us, we'll report it absolutely and understand it, because that then helps us understand what the market's doing. But as we change as every year we look at what we're going to report next, what we're going to do, how we're going to take things forward, we've just had a relook at it. So you won't see this one again, but you will see new ones coming online. But don't ever worry, we're keeping an eye on it, and we will keep that focus.
Okay, on to care provider quality. So this is where the CQC, the Care Quality Commission, have inspected registered providers in Somerset, both domiciliary care and residential and nursing homes. Latest position, actually the chart goes up to May, but since the papers were submitted, we've had June data. So Somerset's position remains at 87.1% of registered providers were rated either good or outstanding by CQC. There are no, at the end of June, there were no inadequate provisions in Somerset, according to CQC. And that's above the 87.1%, is above the national average of good or outstanding, which is 84%. So again, as with the previous slide, that shows a strong, good quality market.
Certainly. My understanding is that if we do have a care provision that requires improvement, we will then work with them to help them get that standard up, because we don't really accept that standard, but CQC does what it does. So we will work to make sure that if anybody did get that, we would try and help them to improve.
Can I ask?
Yeah, certainly, Councillor Bruce.
Thank you. I think we've spoken about this before, about including in this report actually information about how long ago some of these organisations were assessed and inspected, and to see whether any of them sort of these figures, number that have been inspected, but how many of them are waiting for a long time? Are the inspections all very up to date? Is that clear?
Yeah, we've got access to that, and I think we should be able to pull something together that shows probably it'll have to be anonymised and on a sort of group basis. So is it between 1 and 2 years, 2 and 3 years, 3 and 4 years, etc., since their latest inspection? So absolutely, we can bring that back to scrutiny.
What I would say is that Care Quality Commission are doing quite a bit of work at the moment on how they do this better, because they have listened to lots of us and said actually not only our internal inspections, but actually how they inspect the market. So they have just appointed a new director. I can't remember what his title is, but she will tell me off, but a new lead for CQC for adult social care, which will incorporate both our internal and our care market. now I know who they've appointed, I think it will change the perspective of how they do things. I think that will be a good move for CQC going forward.
Okay, now on to care provider contract handback. So this is where providers hand back a package of domiciliary care to the council, and we have to source it with a different provider. Similar to the unmet need one, this is one that you probably won't be seeing in future because it's stabilised significantly. Numbers are a lot lower now than they were a few years ago or 18 months ago. But there was a specific ask the last time this came to scrutiny around what are the reasons for those handbacks. So the pie chart on there breaks down the sort of summarised reasons for those package handbacks. The big pink section is around staffing or capacity. So actually the providers decided they don't have capacity to do that. But the next biggest chunk, so the blue chunk on the right-hand side of the pie chart, is around the client or the family of the client's behaviour. So those are the kind of predominant reasons why providers are telling us they can't deliver that care anymore.
Can I ask a question?
Oh, I'm sorry, Councillor. Sorry.
So these contract handbacks are for individuals, where an individual can no longer, or where the care contracted body can no longer offer the care for that individual. And the range of reasoning is quite interesting, and obviously behaviour, environmental conditions and things like that, I guess are left to the imagination. But what do you do in those circumstances if that care isn't not needed anymore, but is still needed, but they've been handed back because they can't be worked with by an individual or a group?
So in those occasions where there will obviously be a review to determine whether the care is still required, assuming it is still required, it will go back into our care sourcing process where they go out to the market and they try and identify a provider to pick up that care. So in the same way that somebody following a Care Act assessment would go out to the market, they'll do exactly the same process. So when we had significant numbers, so a couple of years ago we had over 200 in a year, that was putting quite significant extra demand on our sourcing team in terms of trying to find that care. To date, to the end of June, we've had 50 packages handed back. So those numbers have dropped significantly. But yeah, absolutely. If the care is still required, it will be resourced with a different provider.
Sorry, just one quick comeback. So do you have to make it known that it didn't work out with somebody else, that there was a particular issue, because otherwise you're just letting people in? I can see the nodding, so that's good. Thank you.
Yeah, we may well end up doing them. Sometimes it's about the approaches that are used for both provider, individuals and families. The best way to work with individuals such as this is to be really open and honest and transparent. And then we do have some providers will want sort of almost behavioural contracts and those types of things that are then undertaken as well, setting very clearly expectations. It's about being open and honest and transparent and finding the right skill sets as well to work with individuals. But we will always look to resource as well. That may well be a different type of provider, or it may well also be looking at some level of direct payments as well. So we get maybe a little bit more bespoke package for individuals.
Thank you. Councillor Bruce, thank you.
Thank you. So the reduction in the number of handbacks at the moment, is that then closely linked to the fact that the market's now stabilised? And do we have an idea sort of, or a feeling, it's a bit of a crystal ball question really, but are we at the point where it's going to continue to reduce? Are we stabilised now, or do you see any kind of risk involved in the next sort of 1 to 5 years with this? Thank you.
So I think it's stable today, and I can envisage it staying stable for a while. We've obviously had the changes in international recruitment. What's that going to do for the market? I don't know yet. We also know that there are new legislation coming in around pay and conditions. Absolutely, I recognise that, and it's the right thing to do. If funding doesn't come alongside that, what does that do to the market? Where's the fragility? We have national insurance increase. What did that do to the market? So today, and for the next 6-8 months, I can't see us having a problem. I think we just need to keep an eye on it. Hence why we won't necessarily need to share it with you, but from a commissioning point of view, this data starts to tell you where are we, what's that market doing. We've got a really good relationship with the market. They talk to us very, very regularly. We meet with them regularly, so we pick it up quite quickly. But I can't guarantee you anything, can I? Like, but what I can say is right now we're okay and we're working with them, and so we'll pick it up both locally and nationally if issues occur.
Could I ask a question, please, about the care providing? Is there ever an opportunity to have 24/7? Because lots of people I know want 24/7, but they think they've got to go to a private. They don't think they can do it through Sunset, and they're very nervous about that. Just wondered if you could help that one.
So yes, we do live-in care, 24-hour care, live-in care at home. Not for everybody, because there could potentially be hundreds and hundreds of people that would want to have live-in care at home. It varies. It depends on risk. It depends on the needs of the individual, because it's not just about the carer that needs to be there. It could also depend on somebody's health needs as well. As a local authority, we would need to look at somebody's needs under the Care Act and then identify those solutions. What we need to make sure of is that we are meeting individuals' needs holistically and making sure that we're providing options for those individuals. But we also, and the Care Act is very clear, that we also need to take into consideration the costs of what that care is, and what the local authority cannot do is be, if we're able to meet somebody's needs and that's their Care Act eligible needs, and meet the wellbeing principle in an alternative provision that is cheaper than, say, live-in care, then we're able to do that, and they're the options that we can look at. It may be that the option that goes to people is, we can meet your needs in this environment at this cost. You're wanting to have your needs met here at this cost, and there may be a top-up that is then required. So an individual may top up in terms of what their Care Act eligible needs are. Now, it's not a blanket approach, and the local authority, and we certainly do not put in a blanket approach, and that's not what we do. We work on it from an individual case-by-case example, because everybody's needs are very different, and then we work with people in very different ways.
So just to define that, so if an elderly person wanted to have a 24/7 person to care, they don't need to go out privately. They can ring social care, talk to them, if they're able to pay, because they don't want to go in a nursing home, but they have the money to be able to pay. How do you assess that?
So regardless of whether somebody has over the financial threshold of funding for adult social care, everybody is entitled to a Care Act assessment. If you meet the eligibility in terms of from a Care Act point of view, yes, you're entitled to a Care Act assessment. Now that can be done in different ways. That could be done over the phone. It doesn't always need somebody coming out to do that face to face. We can do that in different ways. And if sometimes it's quite helpful for people to have an assessment and a support plan, even if they're self-funding their own care, because then they know what they actually need. There may be some times when people think that they need to have the 24-hour care, but it may not be. It may be actually, there could be 8 hours of support a day and a little bit of support here, rather than a full 24-hour care. And sometimes 24-hour care can be more reassuring for individuals and for family members. But yeah, everybody is entitled to a care.
Is that information on our website?
Yeah.
That information is, because they said it wasn't, and thank you very much. That's really good to know. Thank you. Thank you very much. Sorry, John.
Okay. I'll move on to intermediate care. There's a bit of discussion about intermediate care earlier. So what this flow diagram shows is the proportion of people age 65 and over that go home from hospital. So 93.1% of people for May, age 65 plus, went home from hospital. Some of those will have gone into our discharge to assess. So will have received some support at home. Some of them will have received a package of care, but they've gone home. 83.6% of people went home with no formal support. So they may have been supported by the voluntary community sector in getting home, but they didn't receive any formal support in going home. And then I think the final one, we've got a slide around stakeholder feedback. So, I mean, the headline from this is that during the last financial year, so 24-25, over 92% of the responses that we received from stakeholders, from service users, from other colleagues, over 92% rated the service that they'd received as either good or excellent. And that was from about 300 responses. And then the chart shows how that looks on a month-by-month basis. So in May, I mean, numbers are a bit small, but again, it was over 90% of people said it was good or excellent.
Mm. It's funny how it drops down, isn't it? Like April drops. I wonder what happens in April. Not enough chocolate or something, I suppose. I don't know. Sort of weird, isn't it? How sometimes it drops down. But no, I think you can often tell as well, can't you, when people have been in hospital by the amount of cards and the amount of thank you cards and chockies and bits and bobs that are left there. So that's really very good. Anybody got any questions, please?
Just to say, I think that the last slide is actually quite positive. Well done.
Very positive. Yeah, I'm sorry, I didn't mean it to sound it wasn't positive. I just wondered why sometimes it dips. Just wondered if there was a reason. That was what I was meaning. But I think the 92, yes, absolutely excellent. Very, very good. This is a very good summary how you've done this. I'd like to thank you for this, because I think it's made us all understand in detail, but without but easily. And I think that's what we need to be able to understand, to respect the work, the job that you're doing. So thank you very, very much. And I'd like this again at some point when you think it's the right time.
Yeah, I think the plan is, I mean, we need to tie it in with the work programme on a quarterly basis to bring it back. And as Mel mentioned, there may be some slightly different measures next time because we're reviewing them.
We'll also be bringing at the same time the housing. So this is an adult social care and housing service, or a housing and adult social care and health service. Well, I might be changing it a bit. But actually, this is about delivering our housing performance data at the same time.
Okay, excellent. Thank you very much. It's still lovely, the trajectory, I think, to finding that so many more people are at home and not staying in hospitals. And that's my vision, Mel's vision, everyone else's vision, I think. And I love to hear that. So thank you very much, John, for that. Thank you. Okay, right, now we now go on to the last item on the agenda, which is the adult social care CQC readiness. Emily and this is Vicky.
Yeah, Vicky's online, so Vicky's going to lead on this session, and I will dip in and dip out as and when is needed. But Vicky is very capable of leading this session.
Welcome. Thank you. Over to you, Vicky.
Thank you, Chair. Good afternoon, everybody. For those of you that don't know me, I'm Vicky Chipchase. I'm Head of Service for Quality, Performance and Assurance, and going to be giving you a bit of an update this afternoon in terms of our preparation in advance of the visit from CQC. So I've got a couple of slides to share with you. Hopefully everybody can see those. So on the 7th of April, we received notification from the CQC that they were coming to Somerset to carry out their local authority assessment, which determines our effectiveness at meeting duties under Part 1 of the Care Act. And they have an assessment framework that they will apply. And there is a link there in the slide deck for more detailed information in terms of what that framework looks like. But in summary, there are 4 assessment themes you'll see down there on the left, and that's how we work with people, how we support people, how we ensure that people are safe within our system, and then how we deliver leadership in the system. And under each of those 4 themes, there'll be some quality statements. You'll see there in the blue, 9 quality statements in total. And they'll be using a variety of evidence to determine how effective we are at meeting each of those quality statements. And that will be through talking to people, listening to people's experience of services, feedback from people we work with, providers, stakeholders, leaders, and also observation in terms of coming to look at our practice and our processes and more importantly, actually how we're delivering outcomes for the people that we're supporting. So this is the first year that adult social care has been required to be assessed. Quite a large number of local authorities have already had their assessment. What's a bit of feedback coming there? And we're one of the last ones actually within the country to actually have been notified. And some could say that there's an advantage in that because we've actually been able to learn from a lot of other local authorities that have already experienced the assessment, which has been really helpful in talking to others and actually being able to actually shape the way in which we're preparing for our visit. So before they actually come on site, we provide information which is known as an information return. And that's quite a big task in itself, where we had to submit quite a lot of information against a number of criteria. But this is really important because it will help them plan in terms of their visit and really target areas that they'll want to dive a little bit deeper. So we submitted that information return on the 2nd of May, and as part of that, we also have to produce what's known as a self-assessment. Now, if you haven't already looked at it, I would really encourage you to go and have a look. It was a very difficult document to produce because we really wanted to showcase all of the good work that we do across adult social care, but also across our organisation, Somerset Council, but importantly, how we achieve that working with our partners across the health and care system. So we've really tried to capture within that document the key areas of work that we're really, really proud of. But I think what's also important to say is that we really need to acknowledge the areas that we've identified for development, but it's about being able to then provide robust information in terms of our action plans of how we're going to achieve that and continuously improve. And now that we've submitted that, we are now waiting for the date that they'll come on site. And between now and then, we're expecting them to reach out to some of our providers. We know that they've already sent a survey out to our care providers, which is standard practice. And they may also want to contact a number of our providers, partners, and also our community and voluntary sector partners as well. But we don't know the on-site visit date yet, but as soon as we do, we can let you know. But we will be given approximately 6 to 8 weeks notice before that happens. To help our staff and our workforce in terms of preparing for CQC, we have the self-assessment document, but we've produced a really easy kind of summary document, a 2-page summary document there, which really clearly sets out our vision, our principles and our priorities, and also reflects on some of that good work that we've identified within the self-assessment document in terms of what we are proud of and what we're improving. Hopefully some of you would have seen this up across various offices across the county as it's been distributed now across our main offices. Some hard copies are available should anyone want them. Do let me know. Also, as part of the on-site visit, the assessors will carry out what's known as case tracking. Before they come, we'll need to provide them with a number of people, and there'll be anonymised people of 50 people, whereby they'll actually track their journey from start to finish. They'll select a small sample of those 50 to really kind of deep dive into their journeys to really see how we're supporting them to achieve the outcomes that they've identified. Further to the summary document, in terms of workforce preparation, we've been meeting with members of adult social care and been really lucky to have the help from Steve Peddy, who's from Partners in Care and Health, and he's come to Somerset and delivered some face-to-face sessions with some of our staff and our senior managers and also some of our leaders and lead members as well. And then a further online session was held on the 1st of July for all adult social care staff. And this was providing a space for workforce to be able to articulate the areas of work that they're proud of and where they have identified areas for improvement, and to be able to share their plans in terms of how we are delivering against those areas. But this was a really great opportunity for staff to come together. But actually what was interesting, what staff told us really did reflect what had been captured in our self-assessment document. As I mentioned earlier, we've gathered a lot of learning from other local authorities, so we've been able to pull together a slide deck, and there's a link there for you to access a number of questions that we know that the CQC assessors might ask us when they're on site, so this has really helped in terms of our preparation. Before they come on site, we'll be required to deliver what can be up to a 2.5 presentation, which will be on Teams. As you can appreciate, this is quite a long period of times, and for us, we really want to use this opportunity to make a really good first impression. So we'll be delivering the presentation with our partners across the health and care system, but also from the community and voluntary sector, and also with people with lived experience. And this is currently in draft, and what we're suggesting is that we'll cover those 5 areas that we're particularly proud of in Somerset, and that is about our new council, our vibrant communities, our early help and prevention offer, the strength-based practice that we have, and also our partnerships and how we design creative solutions to meet various needs. As part of that presentation, we've been developing a number of stories, and I think what we've really reflected following Steve's visit with us is that we're very good at articulating how we do things, our practice, our policies, and what we actually want to be able to better deliver is actually those stories from a people's perspective, and really kind of demonstrating how what we do delivers those outcomes. And it's about bringing adult social care alive, if you like, through the stories from the people that we support. And there are 3 stories that I've shared here, short video clips. I'm hoping if we've got a bit of time at the end, I'll be able to show one of those to you, but they're 3 for you to look at in your own time. And I think what we'd really strongly encourage everyone to do really is to go and develop your own stories. And a really good way of doing that is through attending one of our talking cafes. And I appreciate you probably won't be able to see on the right there the list of all of the cafes, but there is a link there at the bottom which will take you to a web page. And if you don't know what talking cafes are about, there's a really good short video which really kind of captures that, but you'll also be able to access the list and locations and timings of where all the talking cafes are held. So really strongly encourage you to visit one of the talking cafes and really start to develop your own stories. So next steps is about that ongoing workforce preparation and building confidence across the workforce in advance of the CQC coming on site. Ongoing support to our partners and providers who will also be part of that assessment process. Hopefully you would have seen the articles in the Loop and the highlight report, so we will continue to keep you updated through those channels. We'll also be doing some staff development through some bite-sized online sessions, but also face-to-face through various team meetings. To further develop the introductory presentation for the CQC assessors, and then of course await notification of the visit where we'll get 6 to 8 weeks notice. I'll stop sharing there. I do have a video, but Chair, I do appreciate that it's you're quite overrun. It's just over 2 minutes long, but I appreciate that we might be running out of time, so might not be able to share it, but thank you.
Thank you ever so much. Does anybody want to see the video? We haven't.
It's only 2 minutes.
2 minutes. I mean, I think we may as well. I think we'd like to. I shouldn't say may as well. We'd really love to. Sorry.
Wonderful. Well, there were so many to choose from, but this is really an uplifting one. And this is by the organisation Discovery, who we commissioned to deliver services for people with autism and learning disabilities. So I will share with you now, and hopefully this is going to work. So you can see the power of stories and that has in terms of bringing what we do to life through those stories from those people. So hope you enjoyed that video. Thank you.
Thank you. Thank you very much. My kind of music, I can tell you now. So yeah, certainly inspired me. Thank you very, very much. Does anybody who have any questions, please, they'd like to ask?
I was going to say, do they find a dentist?
Yes, moving on. Councillor Trimmer.
Thank you. Is only a very specific question. So where you've got the to develop your own stories and you've got the talking cafes list, is that the list of everywhere, or is it just an example? Because I couldn't see anywhere in the sort of Shepton or Froome areas, and I just wondered whether there was provision in those areas, and if not, are we looking to build it?
There should be provision across the whole of the council. I will double check that for you now, but yes, there should be provision everywhere, and I know they are in all places across the council, but give me.
I might not know all the villages and places around them, do you get what I mean? But I had a look.
I do, but you're right. I will make sure that they're on there, but yeah, they're across the county.
And I think through the actual web link, you can actually select an area on the map and it will show you where the local cafes are.
Over to you, Emily. Is there anything you?
No.
No question. Well, thank you very, very much. It was very interesting and it's a great lot of work and it's just wonderful to know the inspiration to make everyone's lives important. It's so good. And we thank you for that. Thank you very much. Okay, if with no, oh, sorry, portfolio holder, sorry.
Yeah, I just wanted to say, Chair, if there was anything that you want further information on, I've written down here, you wanted more information on avenues of contact for adult social care, because we were talking about the ways of accessing it, and more detail on overdue care act assessments and how they're, a bit more information from that. So is that something you'd like us to bring back?
Yeah, I also would like I know I can find it, but I'd like it accessible because it seems to be this more and more people are finding now that they want to stay home, but they do need this 24/7 care. But it just seems to be locked in to something that's not very easily for people to find. Is there anything you can come back and give us something more on that the fact that this is accessible, it is out there. People haven't got to deep dive and find it. It's actually going to be there for them first. Because I think I've mentioned this many times. I live in a very elderly area and many people don't realise that they can actually stay home and they just don't, and I don't know why. I try to explain, I try to tell them, I do everything I can and they've been really inspired, but not by what I've said, but what's out there, I mean. But I just feel that with that accessibility, we need to do something to make that the first port of call. I think that's what I'm trying to say.
People who need somebody to come in to see them can have something they wear around their neck or their wrist, can't they?
They need more.
They need more. So do you think they need somebody in the house with them all the time?
Yes.
Well, I don't know, I think what my colleagues were saying, I think traditionally some people would have gone into a care home voluntarily if they wanted that.
I don't want that.
But if they wanted to come and live with them, there are various agencies that provide that, but it's quite expensive. And obviously we could give an assessment about whether that was needed, and it may not be, that it may be what they want, it may not fill within the criteria of care assessment. And if, of course, if they have money, they would have to pay for it themselves, or some of it, because it's means tested. So I'm not quite sure if there's anything else we can add to that.
I'm probably not explaining it very well. I think what I'm trying to say is I have people who don't want to go in a nursing home. They are mentally fine, physically not, would like somebody to come and live with them. I got somebody to live with and a lady to come, and I had to go to a private person. When they acquainted the cost was it was almost cheaper to have somebody living at home with them than what it is in a nursing care. So what I'm saying is, I want people to be able to have that knowledge firsthand, not to have to dive for it. Oh, I'm so sorry.
We can get that knowledge out there for people that are self-funders. That's a really easy option for us. Everybody who provides that care are private providers. So whether they are for-profit, non-for-profit, whatever, they are providers. And we have got a list of the ones within this area that may well come and do that. The challenge will be that we can't do it for everybody that is non-self-funding. And I think that's the bit that we need to make sure people are fully aware of.
Yes.
It has to be meeting their individual needs and appropriate, as Emily described, but we can get that, that's not a problem.
I think it's that division with, I shouldn't be a division, apologies, that's the wrong word. I think what I'm trying to say is there are people who can't, who want, and they'll get assessed and they'll go through the normal way. I'm talking about people who have the means but don't know where to go and are very, very anxious about going to private without the guidance.
So our talking cafes would have that information, all of that information is available out there. But what we can do is I'll double check if we've got it on our website and that's in the right place for us as well. But if they rang Somerset Direct have that information as well. So it's about making a bit of contact. If they haven't got it, I'll make sure they do.
Thank you very much.
We could do a little we could do a little report on those three things that we've now mentioned, bring it back to the next.
Oh, that would be very, very helpful.
Maybe that would help.
That would really help.
I think everybody would like to know.
I think everybody, because we've all getting that, because we're living longer, you know what I mean? And I think we have got to prepare to help people as well, to direct them to the right place. I'll come back to Kelly, but I'll just first go to Emily.
Hello. Hello, yes. Sorry, I'm flashing all over the place.
No, you've died.
Jill,
You've died.
I've died.
Could you use that one?
Thanks, Emily. Is it because an awful lot of people who are at that time in their lives, not necessarily au fait with online resources, point one, and point two, being able to trust private market, so they don't necessarily, it's not that they're not happy to enter the private market and seek out people, but that they want the reassurance from the council, who may be able to say, I mean, obviously it's difficult with the private market in those terms, but to be able to reassure people that wish to utilise those services, but just want that reassurance that they're not going down some sort of scam market, because there's a lot of that that's potentially available. And I think that making sure that they know that there's a Care Act assessment available to everybody, and that could point them in the right direction, along with memory cafes and things like that. I think that's worth promoting to people who have the available resources.
Thank you, well said. Thank you.
So as you're aware, we have been doing quite a lot of events lately, whether they be carers events where carers can come to. We've been advertising those across the county. We had one a couple of weeks ago in Yeovil where carers came along, and we had lots of people there, other people that they could see. It was when we had our days that we've had both online and in person, where people can turn up and ask for information. We absolutely need to make sure that people understand what we can and what we can't do from an adult social care perspective, but actually how they can get information. And one of the things Sarah has been asking for, and I've been polite there, Sarah has been talking to me about, is the fact that how do we make sure the public are very aware of what we do in adult social care. And it was because of that we've been holding quite a lot of events in that space. We'll continue to do that. If you want the dates of all of those events, which I think this may be really useful to you, we'll make sure they come out to you as well, so that you've all got them. So if you want to turn up and find out what's going on, you can do that as a committee. So we'll make sure those dates come out to you via this process.
Thank you. And thank you, Councillor Perstone. You put it in better words than I could have done. But I think it's important that we have to remember there are some people who we all think we can help ourselves, but there are a lot of people in this world who they may financially be okay, but they just haven't got the way of finding that way forward. So yes, absolutely important. Councillor Bruce.
Thank you. Just bringing it back over to the CQC readiness. There's mention in there about the workforce preparation. I'm assuming that members will also be asked questions by the CQC. Forgive me if I've missed any sort of communications, but are there kind of briefings or workshops that are going to be set up for members as well? Because we've got a particular focus or interest on this subject. We're going to look at the key questions and everything, but a wider briefing to all of the members I think would be important. I'm assuming it's already in plan, but.
So they probably won't talk to you as Scrutiny Committee. They will talk to the chair and vice chair of Scrutiny, is probably where they link. They may well talk to Lucy, but not in her role on Scrutiny, and they will absolutely be talking to Sarah. So that's the process that they undertake. What we can do, if you want more information, I know, and we've already helped with some briefing for yourselves and with some support in those areas already. So we've done that as part of this process. I know the next notification date, it's just come out to me, will be on the 14th. So we may get a notification on the 14th, whether we get one or not. But I know that's the next date for us to be told whether they will be coming to see us in the next 6 to 8 weeks. But they won't talk to everybody. They're only here for 3 to 4 days.
Okay. Well, everyone, I've got to say, we've had, apologies for not doing the summings up as I've gone along.
Jill?
Oh, sorry, Emily.
No, it's fine. I just wanted to come back to what you were saying, so it threw me a little bit, saying that there's no talking cafes in Mendip, and I was thinking, I'm sure there are, but they're not run by CCS. So there are, but they're run by the health connectors. So, and you can, if you go onto the website, the Talking Cafe website, it's got a list of all of them, and then for Mendip, it takes you to a different website where all of them are there. So they are there, but they're just not run by CCS.
Oh, interesting. Thank you.
Okay, right then, with that part of the meeting closed, I just want to say, today on the summing up with maternity, we've got a recommendation which we put forward, and Max will send that recommendation to me, please, in words, so that I've got that recommendation, so I know word for word.
Not pictures.
Not pictures, words, so I know.
Can I interject about that? Sorry. Thank you. Is it possible to have that sent around first before we sign off on it? Because the wording, some of us may want to adjust some of the wording or something like that, because it was a little bit free.
We can't do that, we
can't
voted
do
on
that.
it now, we voted on it.
I mean, that's all right.
Sorry, I'm sure you'll like it, Emily, honestly.
It'll be lovely.
I'm sure you'll like it.
Will we get a copy of it?
Yes.
Thanks.
So on the NHS performance, we obviously had that report from David, which I think we gave him exactly what we said. We wanted a little bit more, not quite so clinical report, but we were very appreciative to it. Obviously, the adult care performance was very good, and John realizes, I think that was self-explanatory in itself. So I think, thank you for the CQC readiness. It's, I wish you all the very best of luck, all of you, with that. They're going to have them first hand at the door. But today we are leaving this meeting with a recommendation. So be very proud and very pleased, because this is the way forward. So we need a recommendation, and painting will be sorted very soon. So with that, I'd like to close the meeting, and thank you very much for your attendance.
Thank you.